Good afternoon. It is time to start Young Researchers Invited Lecture. The chairperson is Associate Professor Takashi Nakamura from Tohoku University. Thank you for your time.
Okay, hello, and welcome to our symposium. And we are going to start the Young Researcher Invited Lecture 2. I'm Takashi Nakamura, Tohoku University, and I'm chairman of this session. We are using a Zoom platform, and chat feature on the bottom will be used to ask your question to the speakers. I encourage you to ask a question to the speaker. You can post your question on the chat feature anytime during the presentation. There will be 3 interesting talks in this session, and I'd like to introduce the first speaker, Professor Kyung-Min Lee from Cheongdam University, Korea. The title of this presentation is Digital Approach to Orthodontics, Research and Treatment. Professor Lee, we are ready for your talk, and please share your slide on the Zoom. Thank you.
Thank you for introduction me. Good afternoon, everybody. My name is Kyung-Min Lee. I'm working at Department of Orthodontics, Jeonnam National University Dental School. It's a great honor for me to present here. I would like to talk about today my researches of digital orthodontics. Is my sharing is okay?
Okay.
Okay. Last year, the International Dental Show was held in Germany. International Dental Show is the big global trade fair for the dental community, and the innovation and market trend in dentistry can be shown. The intraoral scanners are important devices in digital dentistry. Over the last 3 decades, there were dramatic change and development in intraoral scanner. Even now, new scanners are continuously introduced and released in dental market. This is my review on intraoral scanner at 2017. Preparing for this presentation, I have updated the scanner's information. You can see that most scanners have been changed and renewed, and the new scanners are released in just 4 years. Regarding the scanner's performance, we can refer to this review by Institute of Digital Dentistry. There are many considerations for choosing the intraoral scanner. We can think the following guideline for the choosing intraoral scanner: scanning speed, scanner size, and price, ease of use, and maintenance policy, etc. I have been using an intraoral scanner for 10 years. When I used the scanner first time, it was too heavy and it required lots of scanning time. As time passed, the intraoral scanner developed more and more, and now I'm using Trios 4 scanner. The performance has greatly improved, and I'm satisfied of this scanner. The accuracy of intraoral scanners are already verified in previous studies. In the comparison of individual tooth measurement and arch widths between plaster model and intraoral scan, there were no significant difference except for intermolar widths of lower first molar. There were also no significant difference in tooth height measurement and tooth width measurement. However, when the two images were superimposed, it was found that there was a little bit difference in the lower second molar area. In the comparison of two scanners, iTero and Trios scanner, They are different company and different technology, but the scanning difference was not clinically significant in orthodontics. When the two scanned images were superimposed, we can see the difference in posterior teeth, I mean the second molar's area. In orthodontics, we are doing full arch scan rather than single or partial scan. So I evaluated the difference of full arch scan and partial arch scan. In the result, the scanning accuracy has a difference between two types of scan in posterior teeth. Regarding reproducibility, we compare the in vivo and ex vivo scan. The result found that discrepancy occurred mostly on the posterior area, and in vivo scan showed more distinct discrepancy. During orthodontic treatment, clinicians take intraoral scan of the patient with the bracket. In the result, even in the presence of a bracket, the accuracy of intraoral scan is clinically acceptable. The region beyond 0.5 millimeter around the braces should be used. Digital technology can be applied to the diagnosis and treatment. Digital orthodontic diagnosis can be used by cone beam CT scan, intraoral scan, and 3D facial scan. I made a new term, blending technique, from the idea that blending different coffee beans creates better coffee flavor and taste. The blending different imaging modalities, such as cone beam CT scan, intraoral scan, facial scan, have many advantages. First, this is the blending cone beam CT and intraoral scan. We have performed the researches about this and found that the registration area affects the integration accuracy. And the cone beam CT image with artifact can also affect integration accuracy. This blending integration of cone beam CT scan and intraoral scan can be used for fabrication of 3D tooth model. And the 3D tooth model can be used for evaluation of root position without repeated radiologic examination. Next is the blending cone beam CT scan and facial scan. As cone beam CT scan cannot show the real color texture of skin, we can use the facial scan image for this. I'm using two kinds of facial scanners, handheld device and ray face with depth camera. In our study, 3D facial scan taken with facial scanner showed the clinical acceptance when compared to the cone beam CT soft tissue image. The another study for integration accuracy, the cone beam CT soft tissue image and facial scan image can integrate in a less than 1 millimeter accuracy. Last is the blending of three kinds of imaging modality: cone beam CT scan, intraoral scan, and facial scan. Our research team published the article titled Creation of the Virtual Patient by Integrating Cone beam CT Scan, Intraoral Scan, and 3D Facial Scan. Digital orthodontic treatment can be applied to the two parts: bracket setup and clear setup. The purpose of this paper was to introduce a digital indirect bonding technique that utilizes a customized virtual bracket setup and 3D printing technology. Indirect bonding technique allowed for accurate bracket positioning and attachment, and reduced the chair time for the treatment of braces bonding. However, they require precise study model fabrication and complicated laboratory process. But this complicated process can be bypassed in digital indirect bonding technique with the use of intraoral scanner, virtual setup, and 3D printing technology. A 16-year-old female visited our department with a cheek complaint of crowding in her anterior teeth. Considering facial profile and incisor inclination and developing maxillary third molar, a treatment plan incorporating the extraction of maxillary second molars and distalization of maxillary first molars was decided. After wearing the headgear for 6 months, intraoral scanning was performed. Then each tooth was segmented using proximal contact points. After tooth segmentation, the facial access point was determined on each tooth, so the brackets could be placed. The facial access point was located at the intersection of the archwire plane and the facial access point of the clinical crown. After virtual placement of the archwire, the type of brackets was selected. Commercially available brackets are available in the software database bracket library. The library is updated by the company. Clinicians can verify the bracket position while viewing the simulated orthodontic movement of teeth. After final virtual bracket positioning, check the final occlusion. A bonding tray was designed. The customized bracket tray was printed out using 3D printer. We sent the file with the finalized bracket position to the company, and the tray with the bracket was delivered a week later. Once the trays were fabricated and delivered, the feed-up tray was checked prior to bonding. After tooth preparation with etching and primer bonding, light polymerized resin was applied to the enamel surface and bracket bases. As the tray is translucent, a few seconds of light polymerization reduce the chair time compared to the time required when chemical polymerization is used. We cut the tray into 3 parts to prevent any debonding of the bracket when the tray was removed. After indirect bonding, 1 4-inch nickel titanium arch wire was placed for initial alignment and leveling. After 1 year and 3 months, the orthodontic treatment was completed. During the treatment, the repositioning of braces was not performed. Using this digital indirect bonding technique, more accurate bracket positioning can be achieved by scanning the patient dentition directly with no need of alternate impression. And the virtual repositioning of the bracket in the desired position and simulating the orthodontic movement of teeth according to the bracket position in real time is possible. Furthermore, the transfer jig and tray can be fabricated using 3D printing technology. Digital indirect bonding technique can improve the orthodontic treatment with many advantages. Next is digital invisible treatment using digital clear setup. This patient visits our department for the correction of mandibular prognathism. He has anterior crossbite and concave profile. After cephalometric evaluation, he was diagnosed as a skeletal class 3 malocclusion. And we planned the two-jaw surgery with maxillary anterior downward and mandibular setback. He wanted an immediate surgery, so without any pre-surgical orthodontic treatment, we constructed surgical occlusion. The predicted seizure bite after surgery will be corrected after surgery using mini screw. This is a digital setup process for clear aligner workflow. First, take the intraoral scan of the patient. Then import into the software for digital setup process. Due to the time limitation, I will skip the detailed process. After digital setup, check the final occlusion. Then export this file to make clear aligners. We send the file to the laboratory technician, and he printed out many types of clear aligners using 3D printer by Envision Tech company. While conventional protocol is to change the aligner every 2 weeks, but in the surgery first approach, we change the aligner every 3 days. Moreover, when fixed appliance is used in the post-surgical orthodontics, the treatment starts from 5 weeks after surgery. Clear aligner can start from 3 weeks after surgery, immediately after intermaxillary fixation. This is before treatment and predicted surgical occlusion, and immediately after surgery. In the radiologic evaluation, the condyle was stable before and after surgery. This is 2 weeks after surgery, and guided splint was delivered for stability of proximal segment, and aligner start 3 weeks after surgery. This is 4 weeks after surgery, 5 weeks, 6 weeks, 7 weeks, 8 weeks, 9 weeks after surgery. At 10 weeks after surgery, the seizure bite on the left side was corrected using palatal mini screw, and transverse correction was done. Mini screw was useful for seizure bite correction. 10 weeks of orthodontic treatment, the whole treatment was done. Digital clear setup can provide the patient more effective and comfortable treatment. This was published in the 2019 issue of Journal of Craniofacial Surgery. Using intraoral scanner and 3D printer, digital bracket setup and clear setup can be used. 3D printing technology is getting popular in orthodontic treatment. Orthodontic appliance can be fabricated in the CAD/CAM and printed out using 3D printer. We don't need to do complicated and time-spending works anymore. CAD/CAM process provides more accurate and more precise work. This is a hybrid type of rapid palatal expansion device. The Hylex screw is commercially available, and I designed and printed out the only connecting bar. Before delivery to patient, check fitness of the device in the model. The connecting bar is made by resin, so the micro etching is useful for mechanical bonding. And the plastic conditioner. Without band and cementation process, just direct bonding is necessary. Patients feel more comfortable because single visit is enough for delivery. Compared to the conventional process, digital technology improved the quality of treatment and treatment efficiency. Moreover, it minimizes patient visit and contact. It avoids messy and uncomfortable process and makes paperless and plasterless dental storage. I hope digital practice would be a new paradigm for post-COVID era. Thank you for your attention.
Thank you, Dr. Lee. This paper now open the discussions. Is any question from audience? Actually, I have a questions for you. Is it I am question for indirect blanket setup method? Is how distinguish the teeth that is anchored teeth and also that the teeth that you want to force or torque the teeth? How distinguish that blanket setup?
To do bracket setup, first we segment the tooth one by one. This process can be automatically and or manually. After segmentation of each tooth, and then we put braces in the program.
Okay.
I'm afraid
so,
I don't understand the question.
Yeah. Okay. So if this technology is developed, the orthodontic treatment is technique is very, very standardized because not require a specific technique. Maybe scanning, printing, and indirect bracketing. Probably it's a very standardized. And do you think that price for treatment is going to decrease?
Yeah, I agree. I understand your opinion. Yeah, but this automatic process, I think, can be technique sensitive. So according to the clinicians or examiner's experience, the accuracy and precision can be different.
Okay.
So all process has to be done by orthodontist, not technician or general practitioner. So the price of orthodontic treatment, this issue can be different. Different issue.
Okay. Thank you very much.
Thank you.
Thank you, Lee. So now we are going to move to our next talk. Dr. Shiwi Chan from School Traumatology, Fujian Medical University, China. The title of talk is Occlusal Disharmony, a potential factor for promoting rat model of depression. So please share your slide, Dr. Jen.
Okay. I shared my screen. Can you see it?
Okay.
Okay, hello everyone. My presentation, the topic is that the effect of occlusal disharmony or promotor depression like the emotions. I will introduce my subject from some items. The depression, it is the common and relapse-prone disease, accompanied by the loss of pleasure and the lack of interest and sometimes even suicide tendency in the serious situations. Many studies have shown that the chronic stress can cause the damage and the depression-like emotions. But the specific mechanism was still unclear. The chronic mild stress was the first to described in 1980s and developed by Winners and his colleagues. Currently, the CMI's model was considered as a prototypical example of the depression animals. But because it has the good predictive validity, face validity, and constructive validity. However, the CMS model hasn't considered the factor related to our dentistry. For example, the occlusal disharmony. The occlusal disharmony it's the disease is very common in our clinic. For example, it's caused by the tooth loss, periodontics, malocclusion, or poor restoration. An early survey identified the malocclusion as a form of stress, and the relationship between the periodontics, the chewing difficulty, and the psychic status. Patients are suffering from the chronic stress appeared to be more susceptible to the occlusal disharmony and might complain about the unexplained the physical symptoms and the mood disorders. For example, the anxieties or the depression impulsions. Moreover, a significant association was established between the frontal deactivating during the chewing or the subscales in the occlusal disharmony patients. Based on a survey, the Japanese patient, the survey, it find that the OD treatment should take into account take into account the underlying the psychiatric disorder manifesting. In the animal experimental, OD was previously achieved by biting raising single crown or the cutting of the cusp. The high anxiety, low probing, and the increasing the CORT were observed in the behavior test. We can find many the studies to see the endings. So it is convinced that the OD can also promote the CMIs-induced the depression-like emotions. However, to our the knowledge, the relationship between the occlusal disharmony, the chronic mild stress, and the depression-like emotions hasn't been rather little in the animal experimental. So the aim of our study was to investigate the effect of the occlusal disharmony and the CMIs on the depression-like emotions and explore the potential mechanism by performing some behavior test or some the plasma concentration of the CORT or the expression of the GR serotonin and serotonin acceptors. Here is my materials and method. First is the animal preparation. As the speaker just ending, she also inferred that the oral scanning. Yes, in our the study, we also use the oral scan for the rights, so we can got the images in our 3-shape. Got the images in our 3-shape, so we can to design to design the vertical prepared teeth in the software, yes, in 3 shape. So we can to print it the TRS guide to prepare the teeth in the mouth. And there is the animal model of chronic particular stress, the CMIs. The rats were subjected to various stress according as the previously we showed in the picture. The stressors were scheduled and altered every day to keep an unpredictable procedures. The experimental design, we showed it in this picture. We divided randomly to the rats to 4 groups: control group, OD group, CMS group, and the combined group. And we induced the OD at the first week, and then induced our CMS at the 3rd week, and the procedure lasted for the 8 weeks. At last, we can to immune chemistry the some chemicals. We can see the behavior test. This is our the OFT test. It's the open field test. It was used to evaluate both the locomotor and the exploratory activities in all. And the second picture, it showed that is the elevate plus maze test. It's examined the rats the anxiety levels, and the last is the sucrose preference test. The aptitude training for the sucrose solution in rats required about 12 hours during the test period. The water bottle and the sucrose bottle was swiped to avoid the rats' preference for the location. It's a very interesting test. We can see the endings. The first result is that we got a new occlusal disharmony animal model. We can see that the con group, OD group, CMS group, and the combined group. You can see that in the CMS group and the OD group, we had the abrasion on the teeth. So we also scanned the teeth and then compared with all we compared with the before we use the oral scan to scan the teeth. So we compared to know the accuracy the operation. We can see that in the OD group we got about 10.5 millimeters in one side, and the other side is 1.5 millimeters. So we got the occlusal disharmony animals model. Then we can see the behavioral tests. The first is I think is the weight test. The difference in the weight among the 4 groups we can see very clearly. The weight gradually increased and reached the highest level in the 8th week, and the change rate between 7 to the 21 days is the 3rd week is that the con group equals the CMS group, and it's more than the OD group and the combined group. But with the time flies, we can see that it changes. The OD group is equals the CMS group, but the combined group is the lowest at the last. The sucrose preference test, we can see that it's also more obvious in our OD group. Also, the evaluated plus a maze test, we can see very clearly in the picture that in all the combined group and the CMS group and OD group, you can see that the mouse didn't go around and just stayed or just go around one one round just stayed here. It lack of the probing. The second is that we can also see the EPM test. So you can see the mass in the OD group, or in the 3 group, we can see that it's more obviously staged in the closed arm. It didn't want to go to the open arm. So we should to discussion this phenomenon. We established the OD and the CMS animals model of the depression-like emotion. Why we say that? An attractive feature of the CMS model is the range of behavioral and psychological changes that parallel to the symptom of the depression. So why we called it that it's the typical model of depression. It's the CMS, but in particular, CMS causes a generalized decrease in rewarding sensitivity and increase the threshold of brain stimulation reward, which is the core mechanism of depression. It's his, we called it the constructive validate in our researchers. Consistent with the previous studies, the preference test was slightly increased in the CMS group. We can see it here. In the CMS group, we can see that it's slightly increased in CMS group and significantly decreased in the OD and combined group compared with the con group in this study. So we indicated that the OD could be better than CMS in affecting rewarding sensitive. Furthermore, the negative correlation in sucrose intake and body weight in CMS model were observed. Yet both were characters of depression-like emotions. OD affects the chewing efficiency or some of the dietary structures, induced a decrease of soy sauce intake and the food consumption. But I think that throughout the endings or the results, we can see that OD exposed the rise displays depressed-like behaviors. Also, we can see that the anxiety emotion in the EPM have described in the animal subjected to the CMS, but it's not commonly observed. The depression-like emotions may associated with the levels of anxiety according to the DSM-5. From the 7th to the 20th day, the significant difference of the rate change in the EPM between the groups. Always the researchers show that the OD was generally considered to the cause of anxiety-like stress. So I think the level of depression-like emotions in the OD associated groups were higher than in the group without OD. So we speculate that the OD, occlusal disharmony, is a good factor in establishing the depression-like emotion models. We can also see that in the open field tests. The second part, okay, but when we do the animals model, but we find that we do the occlusal disharmony model takes a lot of time, and we have to print it the TRS guide, and sometimes we even to destroy the tongue or the muscles in the mouse. So we find later we find another way to create the occlusal disharmony. You can see that we scanned about 60 mouse, about 60 rats the teeth. So we designed the crown on his teeth. and printed. So the first is a cross bite on one side and the other is a cross bite on both sides. Now we can accomplish the occlusal disharmony model in about just 1 minute. It saved our time, and you can see it has the very good results in the Soros preference. The second part is our HPA axis. I think that this is a occlusal. Yes, it's the occlusal disharmony in rodents creates a CRH, ACTH, and the CORT. Yes, okay, the CORT, I think that it's the typical indicator of the depression. The sustained the threats such as the OD further enhancing the secretion of CORT in the rodents in rats. Disrupt the negative. We can see this picture. It shows more clearly. It's the CORT in rats and disturbed the negative feedback system of the HPA axis and induce the hypercamera damage. So compared with the con group, HPA axis activity in our combined group significantly increase. And the other results is serotonin and serotonin receptor expression. We can see in the Western blot is more, it's the ELISA is more clearly. We can see that the serotonin is lower in our combined group, and his receptor 2 is more clearly, it's increased in our combined group. I think that we know that the serotonin systems were assumed to be involved in the wide range of the psychological functions and the different kinds of normal and disordered behaviors. So I think that it's the principal player in the mechanism of antidepressant effect on the PFC or the hyper or sometimes in the PFC or amygdala, or sometimes the region in our brain. So it's I think that his receptor also attract particular attention. It has assumed that it's upregulated in depression-like emotions and anxieties. So in our study, it's coincidence with the previous researchers. So we think that the relation between the depression-like emotions and the occlusal disharmony, we described the transmission mechanism as the picture described. So we got the conclusion. The OD, the occlusal disharmony, might be the promoting factor in the aggressive the levels in or not the CMS rights. So I think that the OD is a good factor for the depression, sometimes even more better than the COMS. This is our conclusion. Thank you for listening.
Thank you, Dr. Jent. Now, excellent talk. Now open the questions. Is any question or comment from audience? Any questions? Okay. From Professor Wakamori, one question is, did you measure the size of hippocampus smaller in your CMS rat?
I'm so sorry, I can't hear clearly. What?
Okay. Did you measure the size of hippocampus in your mouse model?
Oh, no. This is our what we want to do next, because that when we want to do it through the patch or the other ways, you must keep the mass alive. Because if you take out of the brain, the amygdala or the PFC, I think that maybe it's different from in the rights. I don't know if I explained clearly. I just see that when we take out the brain, yes, its size became smaller in the combined group. We can see that, but we didn't measure it. We want to do it in the right, not to uh, uh, through the the MRI or MRI. We want to see the size in the lives, not to take it out, but we are sure to take it out. We see that the size of the PFC or some other regions is became smaller.
Okay. And also another question is that serotonin 2A receptor selective antagonist can be cure your mouse model. Have you tried?
Sorry, I can.
Oh, 5-HT2A receptor antagonist can be cure in your OD mouse model?
No, because we got the with the occlusal disharmony I introduced in my studies. It can't cure, because if you give the white device, example, for the we take the cast off to make the occlusal disharmony. If we want to make the crown to it, maybe a new occlusal disharmony increase. So we improved the occlusal disharmony model now. I just showed in my PowerPoint that we made the crown for his teeth, yes? So we can take it out very easily. That's why I improved the models.
Okay, thank you very much.
Thank you.
Okay, now time is coming, and we are going to move to our next speakers.
Yeah, thank you.
Thank you very much. The last speaker is Dr. Mashita Mandarasari. The title of talk is Oral Medicine Research of University of Indonesia, Exploring Special Need Dentistry, Awareness and Interdisciplinary Oral Health Care. Dr. Mandarasari, please share your slide.
Okay. Thank you for the introduction. Please let me know if my presentation is not shown properly. Good afternoon, honorable speakers, ladies and gentlemen. I hope that you are safe, healthy, and happy wherever you are. My name is Masita Mandasari. I'm an assistant professor in the Oral Medicine Department, Faculty of Dentistry, Universitas Indonesia. I would like to thank the organizing committee, especially Professor Guang Hong, for inviting and giving me the opportunity to share our research in this International Symposium for Interface Oral Health Science 2022 by Tohoku University. The title of this presentation is Oral Medicine Research of Universitas Indonesia, Exploring Special Need Dentistry Awareness and Interdisciplinary Oral Health Care. Maybe not everybody is familiar with these specialties. Oral medicine specialists are dentists who specialize in the management of oral soft mucosal tissue lesions, mainly by non-invasive approach such as medicine, and also the management of oral health problems in medically compromised patients. The latter overlap with the scope of practice of special needs or special care dentist specialists, which also provides oral care for patients with limitation to routine dentistry. The terms special need dentistry and special care dentistry are interchangeable. The background of our initial research was the fact that there have been many publications reporting that special need individuals are more prone to oral health problems, and according to the Indonesian Ministry of Health in 2014, an approximate 2.45% Indonesian population have at least one kind of disability, and this number will keep increasing with time and need more oral health care. Oral medicine is an acknowledged specialty in Indonesia, while special need dentistry is not yet. Although Indonesian dentists who are trained in special need dentistry and have interest towards it have organized the Indonesian Society of Special Care Dentistry. So this was our first research objective. We would like to explore the perception of dentists in Jakarta towards special care or special need dentistry. We did our research by gathering data through an online survey using a questionnaire adapted from the publication of Dr. Derby of her works in Australia. We invited dentists in Jakarta to fill our questionnaire, and in the end, we received 250 responses from 173 general dentists and 77 specialists. We are happy that this research has been published last year and is an open access article, so if you are interested, please read our full report published in PLOS ONE, or you can contact me and I can send you the article. In short, we found that most respondents have poor perception towards special need dentistry, that they reported not receiving special need dentistry components during undergraduate program, that most of them did not perform special need dentistry due to lack of experience. However, most respondents showed their interest in special need dentistry, and they reported to feel positive and comfortable in treating different groups of patients with special needs. From these findings, we concluded that we should introduce special need dentistry in healthcare providers or institutions and to the community. We are happy to announce that our dental hospital has taken the steps to apply special need dentistry in our services. We also thought that we should evaluate all our curriculum of oral health care, and we should also identify the oral health care needs of the individuals with special needs. These became the basis of our subsequent follow-up studies. The first follow-up study was to evaluate the oral health care curriculum. The oral health care in special need individuals is not only related to dentistry, but it's a multidisciplinary approach. So we first tried to determine the baseline of the oral healthcare awareness, attitudes, and perceptions in freshman students of medical, dental, and nursing school in our university. In this study, we used an adapted questionnaire by Professor Haresaku in Fukuoka Nursing College. We recruited all freshman students batch 2021 from nursing, medicine, and dentistry faculty and had a 95.8% response rate. The findings from this study was that most students have good awareness, attitudes, and perception towards oral health, and these are influenced by the student study program. There was a perception difference in the types of population needing oral health care. For example, not all students thought that oral health care is necessary for hospitalized or cancer patients, maternity patients, or psychiatric patients. The students also have different perception on the types of oral health care that should be included in the curriculum, such as oral home care, oral hygiene care, and swallowing exercise. These were our preliminary findings. We expect that we can analyze the data more and publish them in the near future, and also do another follow-up study in several years with the same group of students to see their shift in perception and evaluate the curriculum. We greatly hope that these students will have good understanding towards oral health care and provide their best service to the patients, especially in hospital settings where multidisciplinary care is given. Our second follow-up study from the special need dentistry perception study was to identify the oral healthcare needs in individuals with special needs. Since these individuals often relied on caregivers, their oral health is associated with their caregivers' knowledge. Thus, the objective of this study was to describe the oral health literacy of special need individuals' caregivers. In this study, we are using previously adapted questionnaire, the Health Literacy in Dentistry Indonesian Language, or the Health ID questionnaire, which has the 7 domains composed of 29 items with response using Likert scale. Our study population is the caregivers, both family caregivers and also those caregivers working in formal institutions. This is an ongoing study still on its early stage. From the initial data collection to 21 caregivers in one social institution for special need individuals with multiple disabilities, we got this data showing moderate oral health literacy in general among the caregivers. The domain of economic barrier was scored the least, while understanding of oral health is scored the best in this group. The economic barrier domain covered whether the caregivers have the means to finance oral health care, while understanding domain covered whether caregivers can understand oral health care information if given. We are recruiting more respondents to have more comprehensive data. Once the situation of pandemic is relieved, we also hope that we can gather oral healthcare needs directly to the special needs individuals. This work received a lot of support, so I would like to use this chance to thank them. First of all, to Faculty of Dentistry, Universitas Indonesia, former Dean Professor Lindawati Kusdani, my department, Oral Medicine, and also the postgraduate and undergraduate students involved in the studies. My colleagues in the Faculty of Medicine, Universitas Indonesia, Faculty of Nursing, Universitas Indonesia, Indonesian Society of Special Care Dentistry, Indonesian Dentist Association, especially the ones in Indonesia, and also special thanks to my collaborators, Dr. Hajar Derby in Melbourne University. The funding of these studies is by the Universitas Indonesia Research Grant. I hope that our research interests you, and I will be happy to discuss more. Thank you for your kind attention. Good afternoon.
Thank you very much. It is very good study for that special care dentistry study in Jakarta. So I think this kind of approach you need to support not only for some academic but also require some government.
Yes.
So in the Indonesian government, how support your study and future development of a special dental care system in Indonesia?
Thank you, Professor Nakamura, for the question. So the question is about how our government support these initiatives, right? I think it is good that I am working in a state-owned university. So I think we can start from there because we have more authority to change the curriculum maybe in our university. So that's why we did the second study where we try to evaluate the perception of oral healthcare studies in the freshman students. From this data, we plan to check to maybe evaluate where is the weakness or maybe the strength of these students and their perception to oral healthcare studies. Then we can collaborate with our colleagues in the other faculties to integrate the oral healthcare education into the curriculum so that they can give back to the patients. I think we can start from there, but I think the government is also very supportive. There are several events related to disabilities and also special need individuals. They are actually the responsibility of the Social Ministry of Indonesia. So probably the support of the government is not much, but there is. So we are very optimistic with this initiative.
Thank you. I'd like to hear the good development of your study in your future. Thank you very much. So time is coming. I would like to close this session. Thank you for three speakers. Thank you very much.
Thank you, Dr. Metisa.
Okay, we will now start the keynote session 6, the last session. The theme of this session is biomaterial interface. The chairperson of this session is Professor Osamu Suzuki, Tohoku University. Thank you for your time.
I am Sam Suzuki, Tohoku University Graduate School of Dentistry and chair the keynote lecture Biomaterials Interface session. Let me introduce briefly this session purpose before starting Professor O's lecture. We study in the biomaterials and their interface with the tissues and organs. There is no doubt about the importance of the development of materials and the analysis of the stability of the materials and the imaging of the biomaterials and the surrounding tissues. So we would like to discuss deeply in the exchange opinion with the leading scientists. In this session, we invited well-known professors who have achieved remarkable results in these research areas. Professor Motohiro Uo, School of Dentistry, Tokyo Medical Dental University, Tokyo, Japan. Professor Yuji Chan, School of Dentistry, National Taiwan University, Taipei, Taiwan. Professor Yoshifumi Saijo, Graduate School of Biomedical Engineering, Tohoku University, Sendai, Japan. Professor Jo Sang Kon, College of Dentistry, Yonsei University, Seoul, Korea. Then, although I am afraid I'm also giving a keynote lecture. Then please give the first keynote lecture from Professor Motohiro Uo, Tokyo Medical Dental University. Yes, please start your presentation, Professor Uo.
I would like to appreciate for the organizers to give me the opportunity to make this presentation. Today, I shortly present the application of the synchrotron radiation X-rays for the analyses of biological specimens. Various metals, ceramics, polymers, and composite materials are used for the dental restorations. Metallic materials play important roles as the restorations. However, some types of metallic restorations make the erosion of metallic ions. Then, the eroded metallic ions sometimes cause the various lesions such as metal allergy or contact dermatitis. In addition, the debris of foreign materials cause the lesions such as pneumoconiosis or dermatitis. In order to reveal the causal materials, the detection of trace element or micro debris is important. However, it is not so easy because the target is low concentration and also the human tissue contain the various elements as the next slide. This table shows the major and trace elements contained in the human body. 99% of the human body consist of the light elements, but more than 20 metallic and non-metallic elements are contained as the trace element and some of them are the essential element. In case of foreign-derived elements or materials, such as the eroded metallic ions or micro debris, those originally contained trace elements would inhibit the detection. ICP-AES, the inductively coupled plasma atomic emission spectroscopy, is one of the most popular method for the trace element analysis. Even ICP-AES has high sensitivity, there are some disadvantages for the tissue specimen analysis. Usually, solid specimen should be dissolved by acid for ICP-AES. Nowadays, ICP-AES for solid samples using laser abrasion is provided, but it is not popular. Then, the analysis is destructive and large amount of specimen is consumed. In addition, the trace element concentrations are diluted by the dissolution. Therefore, trace elements becomes more trace and difficult to analyze. Also, the spatial distribution and chemical state information of the target elements in tissues are lost by the dissolution treatment. Usually, the human tissue specimens are provided as the paraffin embedded or frozen specimens. So, if thin-sectioned specimens could be applicable, extra specimen for the elemental analysis is not required. and if the spatial elemental distribution and chemical state information could be obtained without specimen damage, various additional information would be provided. Extremely bright X-ray source, synchrotron radiation would enable the advanced analysis. That is the synchrotron radiation X-ray. Synchrotron is a type of cyclic particle accelerator. The charged particles such as electron or positron are traveling around a fixed closed-loop path. Bending magnets are placed on the loop path to bend the particle orbit on the cyclic loop. While this bending, the electromagnetic waves are emitted to the tangential direction of the orbit. This is the synchrotron radiation. The synchrotron radiation light has the wide wavelength ranging from infrared to X-ray, and the intensity is extremely bright. In case of X-ray range, the intensity of the synchrotron radiation is 8 to 10 orders stronger than the laboratory X-ray sources. In addition, the light is coherent and polarized as the laser light. Therefore, it can be finely focused and monochromatized. Therefore, the synchrotron radiation X-ray is applied for the advanced X-ray diffraction, X-ray fluorescence, micro-CT, X-ray absorption spectroscopy and others. After the beginning of development of the synchrotron facilities, it was the special equipment for the researchers in the most advanced field. However, now 7 synchrotron facilities are in service in Japan. Therefore, it is more familiar for us and becomes our daily tools. In next year, the most advanced synchrotron facilities, SLIT J, will be opened and in service in Tohoku University campus. We applied the synchrotron radiation X-ray for various tissue diagnosis and dental materials estimations. Today, I would like to introduce some of our results listed in here. The first result is the trace element distribution and accumulation in the sequestrum of the anti-resorptive agents related osteonecrosis of the jaw. Bisphosphonate, BP, is most well-known anti-bone resorptive agent. The anti-resorption occurs by the stable complex formation between BP and calcium ion. But, BP forms the stable complex not only with calcium ion, but also with other multivalent cations. For example, platinum complex is studied as the anti-cancer drug, similar to the cycloplatin. In contrast, bone contains various cations as shown in this table. Of course, calcium phosphate is the major component, and magnesium, strontium, zinc, copper, iron, and aluminum are also contained as the minor element. The effect on the bone metabolism by those trace elements, especially zinc and copper, have been reported. Therefore, the study of the trace element behavior in the Iran J sequestrum would be important. We applied the synchrotron radiated X-ray fluorescence for the analysis of trace elements in biological tissues. As the microscopic elemental analysis, SEM-EDS is one of the most popular method. X-ray fluorescence, XRF, is the similar method to SEM-EDS. High-energy X-ray is the excitation source of XRF, then, the characteristic fluorescent X-rays are emitted from the irradiated elements. The energy of characteristic X-rays are element-specific, then, the elemental analysis can be carried by XRF. In addition, X-ray irradiation seldom damage the specimens. Then, XRF is non-destructive analysis. However, the sensitivity of XRF with laboratory X-ray source is not enough for the analysis of trace element contained in the tissues. But, extremely bright X-ray, the synchrotron radiated X-ray irradiation makes possible to detect the trace elements. In this study and the following studies, the microfocused synchrotron radiation X-ray was irradiated on the thin section tissue specimen and generated fluorescent X-rays were detected. With two-dimensional scanning of the specimen, the elemental distribution images could be visualized. In comparison with the pathological images, the relationship between the trace elements and tissue degeneration can be revealed. Those images are the typical elemental distribution images in the normal jaw bone. In those images, reddish color means higher concentration and blue is lower. The specimens were decalcified and thin-sectioned. In the decalcification process, the calcium phosphate was completely removed, then, calcium and phosphor were not detected. Other cations contained in the bones, such as zinc or copper, were usually contained as the substitutional element of the calcium site of the bone apatite. Therefore, those trace cations were also removed by the decalcification and were not detected. In contrast, Oronge sequestrum showed quite characteristic images. The specimen was completely decalcified, therefore, no calcium was detected. However, copper and zinc showed clear and characteristic patterns. This white bar show 1 mm. Those images are the macroscopic images of whole specimen. Next slide is the detailed distribution in this red rectangular region. Those images are the detailed elemental distribution. Spot size is 40 micrometers. Line-shaped characteristic accumulation of copper was observed in the Oronge sequestrum, and zinc showed similar image. The intensity of fluorescent X-ray from copper and zinc were quite high. The maximum concentrations were roughly estimated as several thousand ppm. The typical distribution shows the relation to the bone microstructure. Higher elemental distribution images were obtained by the different method called as micro-PIXE. In addition, the histological image of the corresponding area is compared. CU localization was along the edge of the bone trabecula, that is the region of osteoclasts are accumulated. Bisphosphonate is the inhibitor of the osteoclast and also it forms stable complex with not only calcium but also copper. Therefore, it is assumed the relationship between the copper bisphosphonate reaction and bone degradation. Next topic is the observation of accumulated trace metallic elements from the dental metallic restorations. Oral lichen planus, OLP, is the kind of oral mucosal disease. Various possible causes are suggested for the OLP, for example the medication, infection, physical or chemical stimulation, and metal allergy. Eroded metallic ions are sometimes cause OLP. If we can diagnose the metallic restoration is the causative material of OLP, the symptom can be radically treated by the removal of the restoration. However, there are many possible causes, then, the diagnosis is not easy. We tried the detection of the eroded metallic elements accumulated in the OLP lesional tissues. This slide shows the typical image of OLP tissue specimen. From the synchrotron radiation XRF result, characteristic accumulations of selenium and copper were revealed. This facility is not optimized for heavy element detection. Therefore, another method, micro-PIXE is also combined. Micro-PIXE could visualize the accumulation of silver in the deeper region of the mucosa. The spot analysis at the silver accumulated region, we could find new peaks assigned to indium and gallium. Those four elements are the alloy component of the low-fusing dental silver alloy. Then, it was suggested that they most likely originated from dental alloys. We totally analyzed 12 cases of OLP and similar disease OLCL and compared to the 3 healthy tissues. The effect of erosion of metallic restorations is strongly suspected for OLCL, oral lichenoid contact lesion. Some dental alloy elements were detected by XRF for OLCL. In contrast, the metallic elements could not be detected for normal OLP and healthy mucosal tissues. Therefore, the trace metallic element analysis by synchrotron radiation XRF would be possible to apply the diagnosis of the causative materials of such mucosal diseases. We also applied the synchrotron radiation XRF for the medical diagnosis of the lung disease. Lung is often exposed for the inhaled foreign debris and that cause the lung diseases such as the pneumoconiosis. In this case, we focused the lung disease stimulated by the inhaled tungsten carbide. Tungsten carbide is well-known resource of such cutting tools. Those tools are widely used for industry and also in dentistry. Inhalation of tungsten carbide debris induces typical lung disease called as hard metal lung disease, that is similar to the pneumoconiosis. The definitive diagnosis of this lung disease, the detection of tungsten carbide, the causative material, is important. But inhaled amount of tungsten carbide is quite small, therefore, it was not easy with the conventional method. Therefore, we applied the synchrotron radiation XRF. This slide shows the pathological image and elemental distribution images. The carbide cutting tools consist of tungsten, titanium, and chromium carbides bound with nickel metal. In the XRF image, all four elements could be detected. Therefore, this XRF analysis would be helpful for the definite diagnosis of a kind of lung disease. From next topic, main thesis is the application of synchrotron radiation X-ray for dental materials science. The first topic is the chemical state analysis of titanium in the surrounding mucosal tissues of dental implant. As you know, titanium is one of most chemically durable metals. However, the discoloration, metallosis, is observed in surrounding tissues of titanium dental implants. It might be caused by the micro debris from the implant screwing, but the erosion of implant titanium is suspected. It is important for the safety and biocompatibility of dental titanium implant. How the titanium is contained in the tissues should be identified to estimate the biocompatibility. In order to estimate the chemical state, X-ray diffraction, XRD, or X-ray photoelectron spectroscopy, XPS, are popularly used. However, titanium concentration in the tissues is too low to analyze with those conventional method. Therefore, we applied the X-ray absorption spectroscopy with synchrotron radiated X-ray, that is called as XAFS, is applied. XAFS is the abbreviation of X-ray absorption fine structure, that is a method of X-ray absorption spectroscopy. X-ray absorption spectrum shows the sudden jump at a certain energy, called as absorption edge. The spectrum structure around the absorption edge reflects the chemical state and the surrounding atom coordination. The edge energy is element specific. Therefore, the information of target element can be analyzed without interference of other elements. The near edge structure is drastically changed by the chemical species of target element. Right figure shows the example of copper compound. Copper metal, and monovalent oxide, divalent oxide can be easily identified by this method. In addition, the analysis of expanded absorption spectrum structure, the radial distribution function of the target element can be obtained. From this function, the surrounding atom species and coordination numbers can be estimated. The sensitivity of this method is quite high. Several ppm of target element can be estimated with the modified XAFS method. We applied this near-edge spectroscopy for the chemical state analysis of titanium in mucosa. The tested mucosa was contacted to the titanium cover screw for 3 to 6 months. Therefore, titanium was accumulated in the tissues as shown in those images. X-ray absorption analysis was carried at around the white arrowed spots to reveal the state of titanium. This slide shows the absorption spectra of two different type of titanium accumulated mucosal specimens. Black line is the spectrum of the specimen, blue or red lines are the standard specimens of titanium metal and oxide. In the left figure, titanium in tissues shows the similar spectrum to that of titanium metal. Therefore, the accumulated titanium in this tissue would be the metallic titanium debris, which might be generated by the implant surgery. In contrast, right spectrum shows the different shape. The spectrum derived by specimen was similar to that of anatase-type titanium dioxide. This implant is conventional Brainamark type 2 implant, that has machined metallic surface. Then, the derivation of this oxide should be discussed. This table shows the results of XAFS analysis of 15 specimens. Specimens 1 to 9 derived from the oral mucosae in contact with the pure titanium cover screw through the ordinary second surgery. Specimens 10 to 15 derived from the surrounding tissues of retrieved implants. The chemical state of titanium can be estimated by comparing the XAFS spectra to those of reference compounds. Metallic titanium was mostly suggested, however, titanium oxides were also detected in some cases. Dental implant fixtures in trend are often wear the thick anode oxidation layers. However, as mentioned before, those tested implant is conventional Brainamark Type 2 implant, that has machined metallic surface. So, accumulated titanium oxide was not directly derived from the implant surface. We assumed that titanium oxide would be derived from the erosion of titanium and precipitation as the oxide in the tissue because the titanium oxide is most stable species. In all 15 estimated cases, we detected metallic titanium or titanium oxide. However, most cases are successful in the implantation. Therefore, those accumulation of titanium would not be affected for the implant stability. Because, both metallic titanium and oxide are chemically stable solid, then, the negative effect would not be occurred in surroundings. We applied this X-ray absorption spectroscopy for the estimation of composite resin fillers. Next topic is the behavior of released ions from the composite resin fillers. Some type of composite resin filler provide the bioactive ion release not only the fluoride but also strontium, boron, or others. Especially, strontium ion was suggested various positive effects such as the buffering of oral environment, and the improvement of acid resistance of tooth. In the pilot study of ion absorption into tooth, we found that strontium was drastically absorbed into both enamel and dentin. Initial content of strontium in tooth enamel and dentin was roughly 100 ppm, but after immersion of strontium-containing solution, the concentration was drastically increased up to 10,000 ppm. We tried to estimate how the strontium absorbed into tooth enamel and dentin. In this purpose, we applied another X-ray absorption spectroscopy, called as EXAFS, Extended X-ray Absorption Fine Structure. The spectrum oscillation structure of extended range of after-absorption edge was derived from the resonance of the photoelectron among the target atom and surrounding atoms. Then, the analysis of this structure provides the distance and number of coordination atoms. With using this method, we can estimate the absorbed strontium structure without the interference of other majorly contained atoms such as calcium and phosphor. However, the X-ray absorption around the edge is element-specific. Then, this absorption was only caused by the strontium. And the oscillation structure around this energy range was reflected by the surrounding structure of strontium. This figure shows the radial distribution function of strontium. Center atom is strontium and x-axis means the distance to neighbor atoms from strontium. Y-axis is the coordination number of neighbor atoms. Green is the result from the strontium absorbed enamel and red is from dentin. Blue line is the reference that is synthesized strontium apatite. Those three lines show similar coordination. We can find the oxygen as first neighbor, phosphor as second and calcium as third neighbor. Therefore, the absorbed strontium in enamel and dentin could be suggested as it inserted or replaced into the calcium site of apatite. Last topic is development of novel metal allergy patch test resource and estimation of its behavior. Conventional metal allergy patch is using so acidic and high concentration aqueous solutions. Therefore, false reaction caused by other than allergy decrease the diagnosis accuracy. In addition, low solubility elements such as titanium is difficult to apply by this method. Real metal allergy occurs by continuous erosion with low concentration under neutral pH. Patch test with bulk metal can't induce the allergic reaction because of low erosion. Therefore, we applied the metal nanoparticle called as nanoball for the metal allergy patch. Right figure is the TEM image of tested nickel nanoball. It has roughly 50 nanometers in diameter. In order to avoid the direct contact of nanoball to skin surface, the nanoball suspension was applied to skin via dialysis membrane. With this method, only the eroded nickel ions would penetrate the membrane and absorbed into skin, but the nanoballs were not contact to skin. Therefore, the physical irritation of nanoball can be avoided. We tested how the released nickel ion from nanoball absorbed into skin with the animal test. The nickel nanoball suspension was applied on the mouse back skin. After a certain period, mouse was sacrificed and the skin cross-section was applied for XRF elemental distribution analysis. This slide shows the comparison of nickel ion penetration into skin from novel nanoball patch and conventional nickel sulfate solution patch. In the conventional patch, high-content nickel solution directly applied to skin. Then, the nickel ion was localized just beneath the patch applied point. Then, acute skin reaction was occurred. In contrast, the nanoball using novel patch, nickel ion content was not so high, but it was continuously supplied from the suspension. Then, nickel ion was diffused into skin gradually. Then, skin was not damaged by the nickel absorption. Therefore, the metal nanoball would be a novel metal allergy patch test resource. Those studies have been supported by many collaborators in Tokyo Medical and Dental University, Hokkaido University, Nihon University, and the synchrotron facilities KEK and Spring 8. I would like to acknowledge all collaborators, in the end of this lecture. Thank you very much for your kind attention.
Thank you very much, Professor Uo. I was really impressed with your excellent presentation.
Thank you very much to give me such an honorable opportunity. Thank you very much.
Yes, we have the time for Q&A session. Yep. I have may I ask you
Yes.
question, Professor?
Yes.
Yep. You mentioned about the effectiveness of synchrotron radiation for tissue analysis, and you also mentioned about yeah. I'd like to know the you're using high sensitive method to detect the small amount of element,
Yes.
but what is the detection limit? And this is the first question.
Yes.
Also, I'd like to know you mentioned about the structure of the element to maybe bypass existence of bypassability.
Yes.
So, can you analyze the structure using a synchrotron X-ray? That is the second question.
Yes. Yes. Concerning to the first question, it's the detection limit. It's of course depend on the element species, but usually for the heavy element, it's several ppm it can be detected with the XRF. And if we use some other more advanced methods, the more lower trace element can be detected.
Okay.
And yes, and concerning to the second question, with using the EXAFS, of course we can analyze the surrounding structure, but usually the X-ray diffraction with synchrotron radiation is most popular for the structural analysis, and it maybe makes possible to the trace or small materials the structural analysis.
Okay, thank you very much. And there is a question from Professor Takahashi Baudin.
Yes.
He wants to know about the applicability of fluoride ion.
Yes.
Please explain about that.
Yeah, we tried fluoride analysis of the tooth surface with treated with some kind of the fluorination medication. And we could detect the structural change of the fluorine on the tooth surface. So it is possible.
Okay.
Yes.
It is very interesting. Thank you for your the kind answers. And yes, almost time. So thank you very much for Professor Wu. And
Thank you
please
very
give
much.
a big applause. Thank you very much.
Thank you very much.
Okay, so I'd like to move to the second keynote lecture, which is will be given by Professor Yuji Chan in National Taiwan University, and his title is Biomaterials with Multi-Component Functionalization for Dentin Pulp Regeneration. Hi, could you start your presentation?
Good afternoon, ladies and gentlemen. First of all, I would like to thank Professor Hong Guang and Professor Osamu Suzuki for their invitation. It's my great honor to talk about the research on dentin pulp regeneration at this international conference. And I have prepared two researches using different scaffolds to talk about this topic. Before getting into the research topic, I would like to share two clinical cases. This young male patient had a ceramic onlay after indirect pulp capping for 2 weeks, no, for 2 months. But after the onlay delivery for 2 weeks, a gumboil occurred at the buccal side. Then we arranged root canal therapy for him, and the gumboil was disappeared in 2 visits. The 8-month radiographic follow-up revealed that apical lesion was nearly healed. But after 14 years, a deep narrow pocket was detected at the buccal side. This tooth was diagnosed as vertical root fracture and pulled out for implant. So actually, this case enlightened me a lot that is doing root canal therapy the only options, or we can do something else. According to a study in 2005, comparing teeth with and without root canal treatment, the risk index of teeth with root canal treatment is 7 times higher, especially in the molar area. The possible causes include loss of proprioception, and the shaping procedure in root canal may cause more damage to the tooth structure. So, according to this study in 2012, the survival rate of the tooth after root canal treatment dropped to about 60% after 10 years. So, a minimally invasive treatment would be necessary for the root canal, or we say for the dentin pulp tissue, with the development of dental materials. Biopulp therapy may be in line with this concept. Now let's take a look at another case. This is a 27-year-old man. He has persistent hypersensitivity of the second molar after filling his tooth, and finally comes to visit my clinic because of spontaneous pain. Anyhow, he wanted to save the pulp. Last, we did pulpotomy for this tooth, and we kept the pulp with MTA material. The X-ray shows the material was covered with wet cotton and provisional composite material. After 6 months recall, no clinical symptom and sign. Thus, we suggest to make an onlay for these tools. This is 4 months and 2 years follow-up. The margin of the onlay was good, but we can see the MTA capping tools for body part therapy has changed color. The 3-year X-ray did not appear to have apical lesion, but we need to think about some point. Is the proprioception of these tools the same as before? And if the chamber space is occupied, will it increase the difficulty for doing root canal therapy in the future? And is the underlying dentin was regenerated or just the reparative dentin-like tissue formation? Therefore, we hope we can develop some bioactive materials that can induce dentin pulp regeneration via tissue engineering. As we all know that tissue engineering includes mostly two main approaches. One is cell-based approach. For example, stem cell cultivation and implantation, or xenograft, autograft, allograft, and other cell-containing transplants. Another one is a cell-free approach. For instance, the establishment of scaffolds and carriers. In addition to providing materials with high biocompatibility, some also include signal transmission using growth factors. Next, I would like to talk about two researches we are currently working on related to these two approaches. First, we will talk about the cell-free approach. We try to synthesize a nanocrystalline calcium sulfate by using cryovacuum technique. We can see the SEM pictures. The feather-like crystals have high surface ratio area in which the growth factor could be accommodated. And the X-ray also proved that this is calcium sulfate crystal. And we also developed a porous hydroxyapatite material with chemical co-precipitation method. From the SEM image, we can see a lot of porous structure formations. The porous size is around a few nanometers. So we hope they can hold the growth factors and also provide mechanical strength after crystallization with nanocrystalline calcium sulfate. From the XRD result, the crystals of hydroxyapatite was proved. In this study, we used 3 growth factors. That is VEGF, TGF-beta1, and FGF2. Then we add these 3 growth factors into the different scaffold to see the release profile. We found that the combination of nanocrystalline calcium sulfate and the porous hydroxyapatite showed the largest amount of growth factor release compared to each material alone. So we rename this group as NCSHA growth factors. In addition, we hope this material is degradable material, for the degraded space could be replaced by the regenerative tissue. Thus, we tested biodegradable ability for our material. From this result, it can be seen that the scaffold will be significantly degraded on the 7th day. This is also obviously related to the calcium ion release profile. After the 7th day, there will be a large amount of release. Before 7 days, the calcium ion release profile of our material is similar to that of MTA published by these articles. From this SEM image, we can see a lot of porous space, and also the crystallization of porous hydroxyapatite was covered on it. And we put it into the HBSS solution for 1 day. At the right-hand side image, we can see a lot of the crystallization structure covered on the calcium sulfate. This might be through the dissolution and the recrystallization of the nanocrystalline calcium sulfate and the porous hydroxyapatite. Lead would be benefit for carrying the growth factor and the release after lead. This image is very interesting to see lead. The dentin pulp stem cell cultured on the scaffold and found that the stem cell would form a niche-like structure and grows on it. On the next day, we found that the dentin pulp stem cell grew rapidly and the dendrites displayed projections and present flat, well, and adhere to the substrate of the scaffold. And the formation of synapses between cells seems connected. This image also shows the cell like the scaffold very well. To know the proliferation of dental pulp stem cell on the scaffolds, we did a scratch assay, which indicated that the dental pulp stem cells on nano calcium sulfate and HA growth factor group exhibit higher migration ability than MTA. This implied that the NCSHA growth factor group provide favorable environment for healing process of the tooth injury. And we also investigate some specific markers for dentin tissue regeneration. The result of RT-PCR analysis showed DMP1 mRNA expression had significant difference between extract liquid of our scaffold and MTA after 14 days. The NCSHA growth factor group showed higher effect on mRNA expression of human dental pulp stem cell. And this slide showed the adenosine acid in human dental pulp stem cells for 18 days after culturing with extract liquid of test materials. The adenosine staining demonstrated that the NCSHA showed widespread calcium deposition cluster, which is similar to the MTA group. And the NCHA group containing growth factor showed much more evidence on the red staining than MTA group. That means the dentin pulp stem cell has more calcification ability by the induction of multi-growth factors contain the group. And then we are going to talk about the second approach. That is the cell-based scaffold for the dentin pulp regeneration.
動画が止まってますよ、事務局。
For the cell-based approach, we synthesize a parallel-based material, which can accommodate growth factor and stem cells. This parallel scaffold can be designed as a porous material and carry growth factors via the chemical vapor deposition with ice template. By using this technique, we can design any shape of the scaffold. Also, we can add several kinds of molecules into the ice template. During the sublimation process, the pores inside the parallel material can be formed, and the growth factor can be left in the porous space. The porous structure would then provide the space for culturing the stem cells. So we denote the parallel-based material as PPX here. And then we measure the PPX scaffold by micro-CT and found the PPX had ideal pore space and pore size and a good porosity ratio. We found the protein characteristics of the added growth factors would not influence the pore distribution ratio and size. So we can say the use of such a soil-containing template technique provide a unique method for loading or for localizing bioactive functional molecules. This can be catalyst drugs or biomolecules into the porous materials. And we can overcome the problems of uneven diffusion efficiency via loading materials. Excuse me, is there any technical problem for the recording file or?
Okay, let me check.
Because now should they go to the next slide?
Next slide, yeah.
Yeah. In this experiment, we used two growth factors, the WNT3A and the FGF2, to pack into the ice template. Here, we choose different concentration combinations of growth factor to test the differentiation ability of the stem cells. And we found that under the synergistic effect of these two growth factors, only a small amount of growth factor is necessary and can achieve similar differentiation effect. And in this slide, the left-hand side corner, we can clearly see dental pulp stem cell grew into the PPX scaffold. In addition, we also studied the effect of dental pulp stem cell differentiation on growth factor contained PPS. We found that they significantly increase both OCN and DSPP expression. It is speculated the PPX with such growth factors has very high potential to encourage the dental pulp stem cells to differentiate into odontoblasts. And the right-hand side, we can see the SEM image showed the dental pulp stem cells differentiation into the scaffold, and the process of the cell can be seen clearly and extend into the scaffold porous area. And now, I would like to summarize of our core concepts about dentin pulp regeneration we used with this slide. We hope that the capping material, which can be biodegradable, or to be the porous material, which allowed to provide a hotbed for odontoblast cell differentiation through the stem cell homing. As soon as the signal from the scaffold release, this bioactive signal will encourage the stem cell or mesenchymal stem cell differentiate into the target cell. This means they can be differentiated to the odontoblast cell and then mineralized to form the tubular dentin, to form the biomineralization combined with the nerve regeneration. So that we hope this regenerated blood vessel and the nerve can achieve true dentin pulp regeneration and restoring normal nerve sensation and the regeneration of true tubular dentin. At the end, I would like to express my sincere acknowledgement to some of my friends listed here. We always get together and share the idea with each other and do the researches together. We really enjoy the time. Thank you. Thank God for giving me such friends and the opportunity. And thank you everyone here for your attention. But this is not the last slide. Before the Q&A, I would like to take this opportunity to promote an upcoming international conference which will be held in Taiwan this year. That is International Dental Material Congress, and this year's theme will focus on Step Ahead toward the future of dental material science. So, what day are we going to hold? It will be on the November 4th and 5th, the Friday and Saturday. Please kindly book your schedule here. And which city is held in? The IDMC will be held in Zhang Rongfa Foundation International Convention Center, which is located near the National Concert Hall. The concert theater and the concert hall often have great performers, and I believe you can also take the opportunity to visit. One of the highlights of this conference is our keynote speaker, Professor Jack Ferricaner from Portland, and he is definitely a remarkable speaker in this field. Besides, we have also invited other well-known international speakers from Japan and Taiwan. What is more worth mentioning is that the international speakers include research scholars from academic and industry background. As you can see here, the Dr. Mi is the general manager of a biotechnology company. So through the Congress, we would like to engage all of you with professional idea exchange, research discussion, and future collaboration. Once again, I am delighted to invite you all to take part in this Congress and explore the wonderful Taipei city together. Welcome to Taiwan. Thank you.
Professor Yu Chan, thank you very much for your very excellent lecture and also kind of introduction of our IDMC 2022. Thank you very much. Yes.
Thank you.
Yeah. So your keynote lecture is open for discussion. We have a little time for we accept a question or comment from the audiences. So may I ask you first, Professor Ichi-chan?
Yes.
I am very interested in your scaffold research, and I have two questions. One is you mentioned about NCSHA growth factor scaffold, and you explained about biodegradation by monitoring of calcium ion release, right? Which materials degrade from first, calcium sulfate or hydroxyapatite? Which one do you think?
Yes, that is a very nice question. Yeah, so I'm currently also wondering which one is the first. By testing the degradation individually, we found the nano calcium sulfate is first degrade, and the following and the hydroxyapatite is following. Yes.
Okay, that's very interesting. And that may have a second question.
Yes.
You mentioned about 3D porous scaffold composed of the PPX growth factor, the porous scaffold, right?
Yes.
And you mentioned you explained about the pore size of the scaffold, which showed approximately 20 micrometer diameter. Is that correct? Correct?
Yes.
Okay, so in that case, I think the cells cannot be entered inside of the scaffold. So, do you expect the biodegradation, with the growth of the tissue during the release of the growth factors, or 20 mic? Yeah, do you think that cells can be?
You mean this scaffold can be degraded, or you mean the pore size it's suitable for a cell homing, or so?
Yeah, because ceramics materials, bioceramics materials, usually 100 micrometer diameter is needed for the ingrowth of the cells.
Yes.
So that's why I asked you.
Yeah. Actually, at the beginning, I want to develop a pore size around the 50 micron, better for the odontoblasts cell the differentiation.
Yeah.
And then we found it's just in average around the 25 to 30 microns. But for cell forming or for niche, you are right.
100 micrometer is better for the cell homing for living there. But now we are aim to carry the stem cell, and because after that they will recruit or release some signal by themselves and produce the microenvironment very similar for the dentin pulp regeneration.
Okay.
So it's not for cell forming.
Yes, yes, I understand.
Yeah.
Thank you very much. So, are there any questions? Or if there is no questions, that and the time has come. Thank you, Professor Chan. Thank you very much.
Thank you very much. Thank you.
Thank you. Okay. So I'd like to move to the third keynote lecture, which will be given by Professor Yoshifumi Saijo, Tokyo University. In the title is Possibility of ultrasonic photoacoustic imaging of oral cavity. So Professor Saijo, could you start?
Yes, thank you very much for giving me such an opportunity, Professor Suzuki and everyone. I'm Yoshifumi Saijo from Tokyo University Graduate School of Biomedical Engineering. And this is a brief personal profile. I graduated from School of Medicine, Tokyo University, and I am a cardiologist. But now I'm very interested in the ultrasound and photoacoustic imaging. And today I will introduce our activities. And first of all, I should say Tokyo University is very proud of the collaboration of medicine and engineering. And this is a magnoscope. That is a kind of the electrical stethoscope developed in 1924 by the collaboration of Professor Akira Sato. He was the professor of the pediatrics, and also Professor Heiji Nukiyama, and he was the professor of electrical engineering. And now, this is the second biggest collaboration between medicine and engineering. And this is a collaboration by the Professor Motonao Tanaka, and he is actually my professor, and Professor Yoshimitsu Kikuchi at the Institute of Electrical Communication. But of course, today, this collaboration is not limited to medicine and engineering. And in Tohoku University, we have already established a promotion of medical science committee, and there are so many research institutes and the faculties and graduate schools are gathering together to develop the medical device. And of course, including dentistry, School of Dentistry and Graduate School of Biomedical Engineering. First, I should say I would present some of our activities in ultrasonic imaging. And maybe you know ultrasound imaging is very popular. And this is the targets of ultrasound imaging, classical targets. And the thyroid, breast, spleen, pancreas, uterus, kidney, gallbladder, liver, heart, carotid artery. And today, the application is a little bit widened to transcranial and lung imaging, colon imaging, joints imaging, muscle imaging. And this is the conventional clinical ultrasound image, and this is liver, this is heart moving. And I will introduce the status of the medical imaging modalities in Japan. And this is a sales numbers in 2018. And these ultrasound machines are sold 13,581. And X-ray is 9,000, CT 1,000, MRI 474, like this. And of course, today I should use a little bit different slides because some of you are using the dental X-ray or dental CT like this. And this is the procedures and the medical expenses of medical imaging in Japan. And this is the survey on June 2018. And the procedures is biggest in the X-ray, because we cardiologists also use the X-ray for the chest röntgen. And the ultrasound is something like this, and CT is like this. And the expenses is the biggest in the city. And the ultrasound, X-ray, angiography is almost same. And again, I say medical ultrasound imaging is always characterized as easy, safe, portable, inexpensive imaging. But that's not all. So today I will introduce some of the newest ultrasound imaging. And one is ultrasound imaging is functional. And I will introduce spectral tracking and shear elastography and blood flow. And this is the spectral tracking, and this is a little bit complicated, but you compare two frames, and you are very interested in this structure, and in the next frame you should find the same structure, and if the movement is like this, you can get the velocity of the tissue movement. And this is a strain imaging clinical echocardiography, and the heart is always moving. So we can find the same position in the different frames. And if we apply this technology to the shoulder joint imaging, the patient should move their shoulder like this. And we are focusing here. And this is the ultrasound imaging, and this is the humerus, and this is the coracoid process, like this. And this is a humerus, and this is a coracoid process. And in frozen shoulder, and this region is adhesion. So now we are very interested in the movement of the deltoid muscle and the supracapillarities. And this is one of the examples of the movement. So if we track the movement here, and the tracking is different, and this difference means this is moving and this is not moving. That move means the adhesion of this layer is not so much. And this is a velocity vectors in normal subject. Again, this is moving, here is moving, but here is not moving. This indicates this is still and this is moving, so the interface here is not adhered, not fixed. But in case of the adhesive capsulitis, this is one of the frozen shoulder. At this time, both regions are moving. That means this interface is a little bit adhered and fixed. And this is a summary of the adhesion index and the range of motion of the shoulder joints. And here, adhesion index is a ratio of velocity of the deltoid muscle and the subcapsularis movements. And there are weak, but some correlation is found here. And next, I will introduce the shear wave elastography. And this is the focused ultrasound wave. And at that time, this shear wave, this is a perpendicular to the ultrasound wave, is generated. Sorry. And if there are some hard regions here, ultrasound propagates faster. So the shear wave imaging is something like this. And this is the company of the Canon, Toshiba Medical, Canon Medical proposed this shear wave elastography. And the other companies summarized this movement and converted the movement to the elastography, shear wave elastography, elasticity. And this is a benign tumor, and this is a malignant tumor. Maybe you cannot see the very big difference between these normal conventional ultrasound images, but this benign tumor is soft, but this malignant tumor is very hard. So you can distinguish benign and malignant tumors by this shear wave imaging. But of course, the shear wave imaging machine is very expensive. So we thought if we can generate the shear wave by the more cheaper material. This is just a speaker. This is maybe $20 US dollars or something. And this is generating the shear wave. And if we observe the normal ultrasound transducer, the shear wave propagation, we can make the very cheap shear wave elastography for using the conventional ultrasound machines. And the normal machines have the color Doppler imaging, and this is a B-mode imaging, original ultrasound image, and now this is vibrating. So the vibration can be detected by the conventional color Doppler image. And we converted color Doppler to phase map, and we calculate the shear wave velocity and also shear wave direction. So maybe you can see some structures here, and this is a hard inclusion in the soft material. And now you can see the shear wave elasticity is a little bit different from here to here background, and also shear wave direction is different in the background and this inclusion. And again, these are the current targets of ultrasound imaging. So how about oral cavity? And I am not very familiar with this, but I searched some papers, and this is maybe the early report on intraoral ultrasound. It was published in 1987, and the intraoral ultrasonic scanning as a diagnostic aid. And they compare the clinical imaging and the excited because these are the tumors and surgically excited, and they compare the ultrasound imaging and the structures. And this is a recent publication, and this is a recent ultrasound images of oral cavity. And now you can visualize the sublingual gland, buccal mucosa, tongue, and also some researchers are using ultrasound as the diagnosis of the squamous cell carcinoma, SCC. And in this paper, they use the hockey stick transducer. And this is the number of elements is 128, and the frequency range is between 7 to 15 megahertz. And this is something like this visualization. And they say the hypoechoic lesion abutting the left hemimandible at the retromolar trigone with a hyperechoic line indicating the gingival cortical margin of the mandible. So again, I'm not familiar with the anatomy of this, but they say this bright black area, hypoechoic lesion, and this is a very high area. And also here, they can find some blood flow by color Doppler echography. So I think blood flow detection is very important because the detection of small blood flow in tumor is important for diagnosis of cancer. And in clinical ultrasound, of course, color Doppler imaging is established, and also other is the contrast agent used. Now you can see this is before the contrast, and this is a conventional echocardiography, and you can visualize the tumors because tumor has a lot of vessels. So this is stained, and this is contrast. So one of the my proposal is maybe you can use such contrast imaging in the clinical dentistry. And of course, there are some other images, and this is SMI proposed by the Canon Medical, and you can see the very small difference between these conjunctive frames, and you can see the blood flow. And this is made by GE, and they are enhancing the red blood cell in here. And in our case, we developed the singular value decomposition method. So today I have prepared so long versions, so I will skip this. But anyway, we have some images, and this images is space and time, and space, time, and matrix. So if we analyze this matrix, we can visualize blood flow like this. And this is a carotid artery in long axis, and this is thyroid gland in long axis, and you can see the very small arteries here, and this is a carotid artery short axis. Again, you can see the carotid artery, and also you can see the small vessels. And this is our second topic. And of course, if you use the new transducer, and maybe you can design the different type of the transducer. And I'm proud of Japan has some opportunity to make the very specialized transducer. And the Canon Medical have already this hockey stick and the higher frequency hockey stick transducer in market. And this is our own transducer because we can design and we can fabricate the ultrasound transducer. And also I want to say ultrasound imaging is scalable. So if we are using the higher frequency ultrasound, we can achieve the higher resolution imaging. And this is very simple equations. This wavelength is inversely proportional to the frequency, and also the ultrasound beam width also inversely proportional to the frequency of ultrasounds. So if we use the higher frequency ultrasound, we can have the higher resolution image. This is a vein, and you know vein has a valve, so you can see the vein flow and the valve here. And this is 11 megahertz transducer. And this image was taken by the 38 megahertz transducer. And of course, the resolution is much better in the higher frequency transducer. So I can say we are using lower frequency ultrasound for the echocardiography of abdominal US, and for the carotid artery or breast thyroid imaging, and also in the slides of the squamous cell carcinoma of the oral cavities, you can use the middle ranged. And today we have the much higher frequency ultrasound imaging in the special case of endoscopic US and intravascular US. And much higher, we have the ultrasound microscope. And this is our very original research. And this is the comparisons of the various microscopes: optical, electron, atomic force, acoustic microscope. And the resolution is something like this. And the visualization of the optical microscope is a visualization of the chemical properties stained of the tissue. And the electron microscope visualizes the morphological. Atomic force microscope visualizes the topological or mechanical properties. And the acoustic microscope can visualize the physical or mechanical properties. And maybe I can skip this, but I want to say elasticity, viscosity, these both of these are very important parameter of the tissue elasticity or tissue mechanical properties. Both are closely correlated with the sound speed of the acoustic impedance or the absorption frequency, ultrasound. And this is a scanning acoustic microscope. Acoustic ultrasound is focused, and this transducer is scanned over the specimen. Now we have the newer version, and here this is the optical image, and this is ultrasound image, and this is the vessel, and this red indicates the higher sound speed, and this red indicates the high elasticity. And here this is the same intima collagen fiber, but this is very weak on the collagen fiber, exhibiting the low sound speed. And the difference is something like this. Here, the speed of sound speed is 1670 meters per second, and the electron microscope shows this very thick fibrils. And here, the sound speed is lower, and the electron microscope reveals the very thin fibrils. So we can estimate these ultrastructure by measuring the ultrasound, speed of sound. And this is the other experimented degradation of collagen in facial skin. And this is attenuation, this is the sound speed, and we rinsed the tissue in the collagenase, and the collagen, some of the collagen was degenerated. Then 30 minutes later, the acoustic properties are changed. And now we are making the multimodal ultrasound microscope. So this is a conventional acoustic microscopy, and this is a C-mode imaging of the thinly sliced tissue of single-layered cell. And this is ultrasound impedance microscope, and this is a 3D microscope. And again, this is a conventional acoustic microscope, so tissue should be this slightly thin. But in case of the ultrasound impedance microscope, plastic plate is placed on the tissue, and the ultrasound reflects at the interface between the plastic plate and the tissue. So thin slicing is not required. So I believe this technology can be applied in vivo. And this is a movie of the ultrasound impedance microscope. So tissue is placed here, and you can see the scanning here. And also, again, this is a movie, and this is the monitor. And now this is the scanning. This is a real time, and it takes almost 1 minute. Then we can calculate the impedance. And this is the example of the ultrasound impedance image of the rat brain. But in case of the very hard materials, maybe we don't need the interface here. So if you polished very good, this is very flat. So ultrasound is reflected at the tissue surface, and we can get some mechanical properties of the hard tissue. And this is one example of the new bone formation here. And this is the adhesion between dental cement and dentin. And this is the optical macroscopic image, and this is the ultrasound image. And I heard you're using this staining for the conventional diagnosis of dental caries. And this is the staining, and some experienced dentists can choose the best strategy by this But I think this is very objective and qualitative. Dr. Naganuma at the School of Dentistry, he compared the NUP hardness measurement and our ultrasound impedance microscope. And I'm not familiar, but this has some cut here, and this NUP device has a various hardness, and if you can have a cut here, this tissue is weaker than this. I'm not sure, but that is the and this is the specific acoustic impedance here, and you see these are different layers, and this is carriers, and the carriers have some different acoustic properties. And Dr. Naganuma compared the NUP versus specific acoustic impedance, and they have a good correlation. So from today, if you use the acoustic impedance, you can in vivo measure the hardness of the tooth, and you can decide treat or observe. And this is a higher frequency ultrasound transducer. And if we increase the higher frequency, we can observe the cell. And maybe I should speed up. So this is the change in the morphology of the biomechanics during temperature change. And this is the change of the morphology and biomechanics. And so now we can observe the single cell, and we can observe the cross-sectional image of the single cell. And this is a nucleus, and the nucleus is surrounded by the cytoskeletons, and cytoskeletons is always more elastic than the nucleus. And finally, photoacoustic imaging. This is an easy principle of photoacoustic imaging. Short pulse laser absorbs the light energy and transforms the heat energy to the sound. And this is the comparison, and this is a prototype. And this is the vasculature of the nail bed. And also this is a penetration depth of photoacoustic imaging. And we are developing the almost 1 millimeter photoacoustic imaging. Maybe I should skip this. So something like this, we can get the image of the skin. And this is ultrasound image, this is photoacoustic image. And these are superimposed, like this. And if we use two different wavelengths, we can estimate the oxygen saturation. And this is some images. And now we have developed real-time 3D photoacoustic imaging. And using this machine, we can visualize a very small stream of the red blood cell in a very small vessel. This is a human palm. And finally, I will introduce our high resolution photoacoustic microscope. And this is a red blood cell, and this is a melanoma cell. So, and in the summary, ultrasound imaging is scalable from macroscopic to microscopic imaging. And nano-level resolution imaging of a single cell is achieved by the photoacoustic imaging. So thank you for your attention.
Thank you, Professor Saijo. I was really impressed with your excellent presentation. And this is open. A normal to produce share wave in, well, it has to. Saijo Sensei, can you read it?
Yes. So, we can use normal speaker to produce shear wave in shear wave. Yes. Shear wave is just a wave. So if we generate the 80 hertz by the normal speaker, we can generate the share wave. So it's very, very easy to make the share wave. Yes.
Okay, thank you. And I have may I ask you one question?
Yes.
You mentioned about the resolution of
Resolution, yes.
your technique. Then I think maybe it can be applied to the molecules, not only the cell level, but also the molecule. Do you
Yes,
think
yes.
that molecules can be detected
Yes,
by?
yes, yes, yes.
Oh, it's a bit really interesting. So although the audience has a lot of questions, but the end time has come. So thank you very much for Professor Saijo. Thank you very much.
Thank you
Big
very much.
applause. Okay. And so let's move to the first lecture, keynote lecture, which will be given by Professor Jo Sung Kon from Yonsei University. So could you start your lecture, keynote lecture?
Good afternoon, ladies and gentlemen. My name is Jae-sung Kwon. I'm from Yonsei University, College of Dentistry. First of all, I would like to thank Professor Nobuhiro Takahashi and Professor Kwang Hong and all the organizing committee of the International Symposium for Interface Oral Health Science 2022 for the invitation. The title of my presentation today is Incorporation of Novel Bioactive Components for Functional Dental Materials. As I said earlier, I'm from Yonsei University, College of Dentistry, where we are located in Sinchon at Central Seoul. We have more than 100 years of history, where we've been formed in 1915 by missionary, and since then, we had a lot of research and development. A few years ago, we had a MOU between Graduate School of Tohoku University, where we are maintaining a very good relationship with Tohoku University, where the previous dean, Professor Keiichi Sasaki, has visited us last time. And my department name is Department and Research Institute of Dental Biomaterials and Bioengineering. And I also belong to a Dental Device Testing and Evaluation Center, which is a evaluation center approved by Ministry of Food and Drug Safety, the Korean FDA, for issue of official certification for dental medical devices. For these reasons, I'm very interested in different dental biomaterials and also dental medical devices, as well as international standards. Among many different research topics, I would like to go through 4 main topics that we are recently interested in, which were nanodiamonds, hydrated calcium silicate, bioactive glasses, and Zivitron materials. So first of all, we were interested in the development of nanodiamonds in different materials. So you probably realize there are new different materials with advance of digital technologies. For example, CAD/CAM materials and 3D printing materials. However, despite being advancement of these materials, there are still limitations, especially related to mechanical properties. And a lot of different potential materials has been investigated by different researchers, but we focused on nanodiamonds. Nanodiamonds are carbon-based nanoparticles, which are biocompatible and superior in terms of mechanical strength and surface hardness in bulk form. Despite its name being a diamond, it's actually low cost of synthesis with antibacterial and antifungal effects being investigated by a few researchers. So we published 2 papers recently that wanted to investigate incorporation of this nanodiamond in different materials. First of all, we just incorporated into a monomer liquid or PMMA, which is commonly used for denture materials or orthodontic retainers. As you can see here, it actually has significantly in terms of statistic with the flexural strength and elastic modulus, as well as viscous hardness, and the effects were more significant than zirconia, which were the material that's been commonly investigated for possible use to improve mechanical strength. But not only that, it actually had some antifungal effects. As you can see here, compared to zirconia, it has a dramatic reduction of Candida albicans colony forming units, and as well as the oral biofilm formation, as you can see here. So we wanted to incorporate the nanodiamond to digital materials such as 3D printing materials in this time, not just incorporating nanodiamond, we had some surface modification of nanodiamonds, for example, the amination of the nanodiamonds. And this outlines how we prepare the samples, and the results were, as you can see here, so that the aminated nanodiamonds will further increase the flexural strength and impact strength, as well as the elastic modulus and modulus of resilience. It has also impact on the viscous hardness, where the changes in surface roughness before and after the toothbrushing simulation were pretty much minimal, which indicated that this is a very durable way of controlling and providing a higher mechanical strength. So provision of this higher or improved mechanical strength with nanodiamond was very interesting. But we wanted to go further than that. We wanted to have some bioactive results in terms of antibacterial, antifungal effect addition to this nanodiamond. Perhaps we turned our head to this hydrated calcium silicate for this region. The calcium silicate is increasingly used, and you probably heard the name before, as a mineral trioxide aggregate, MTA, which is commonly used in endodontics. The reason for it's been very popular and widely studied in recent years is because it's biocompatible, but also bioactive. It provides alkaline pH with ion release, and in recent years, the hydrated calcium silicate also attracted a lot of interest because they provide a dentino-tubal occlusion for a prevention of hypersensitivity. The picture down here is the result of interlaboratory studies we carried out with the 4 different MTA. When they are immersed in the simulated body fluid, the apatite is formed, indication of their bioactivity, and perhaps the indication of the regenerative effect that's been heavily investigated for these kind of materials. So we wanted to investigate whether we can use the hydrated calcium silicate for resin-based materials such as peat and fisher sealants or a tooth whitening agents. As you can see here, the calcium silicate, when they're hydrated, they have different appearances, as you can see here, which we analyze with EDS, is a calcium and silicate-based structures on the surface of these kind of materials. So as I said earlier, it provides a alkaline pH. So when they are in a acidic conditions, like pH 4, it dramatically increases the pH to neutral or even alkali environment, and they are relatively maintained a longer period when the high dose of the high amounts of the hydrated calcium silicate has been added. Also, both in distilled water and lactic acid solution, they release calcium ions, which is responsible for this dentin tubal occlusion. As you can see here, compared to control, there is a more occlusion of dentin tubal when they have a high level of hydrated calcium silicate. And when we analyze these particles here, is calcium and silicate-based materials. So when they are made into calcium silicate into the composite resin or peat and fisher sealant, at the lower dose of the calcium silicate, they maintain the mechanical or physical properties relatively well. However, at the higher level of the contents, obviously there is a more reduction of depth of cure or water absorption or water solubility and so on. However, certainly they have a good bioactive results because, as you can see, when we have a demineralization and then expose this demineralized surface with calcium silicate, the percentage of microhardness loss is dramatically reduced, or even a gain of microhardness when we have a hydrated calcium silicate, which indicate the hydrated calcium silicate not only neutralize pH, provide alkaline pH, and also provide ion release, but also they have an effect in terms of the prevention of demineralization and also remineralization related to these microhardness results. So we then focused on different materials related to this bioactiveness. Obviously, bioactive glosses is one of them. So I think the bioactive glosses are a huge fashion in dental materials. A lot of different labs are investigating bioactive glosses, and there's actually products out there that started to incorporate bioactive glosses into resin or different kinds of dental devices. And the bioactive glosses are glass-like materials with addition of bioactive components, for example, the calcium and phosphate. Initial bioactive glasses, or most famous bioactive glasses, 45S5 bioactive glasses produced by Professor Larry Hench. But our aim was to modify this kind of bioactive glasses to suit their need, whether we require high level of strength or even different bioactive nature. So here we wanted to form a zinc-doped phosphate-based glasses. So on these phosphate-based glasses composed of phosphate and calcium and sodium-based composition, we added a zinc oxide into a composition of glasses, and we formed the amorphous glasses, as you can see here. The reason we added zinc oxide is to provide antibacterial properties to this flowable resin, and therefore we added these glasses as a filler of this resin matrix in different proportion, as you can see here. And by adding it, obviously, up to a certain point, it decreases flexural strength, but it did not really have the effect on elastic modulus or depth of cure, a very minimal effect on the micro hardness. But certainly with our aim, the addition of zinc-based phosphate classes will reduce a Streptococcus mutans CFU, as you can see here, with the antibacterial effect. There's perhaps the reason being a released zinc ions from this kind of glasses from resin matrix out to outside. We also wanted to improve some mechanical properties in weight-bearing areas. So here we incorporated zirconia oxide into 45S5 bioactive glasses to modify this original composition. It certainly improved the viscous microhardness and fracture toughness as we increased contents of zirconia oxide. And it improved the neutralization of acid or making it into alkaline environment and release a ions that is responsible for activity. And certainly this release results in a formation of apatite-like structure when they emerge in simulated body fluid for 14 days. So as you can see here, compared to 45S5 bioactive glasses, the bioactivity is relatively well maintained. And when we carry out some in vitro and in vivo studies, it was evident that these bioactive glasses still result in a formation of bone-like cells activities with these ALF activities and allergen staining. And when we implanted this to subcutaneous tissue, there was bone tissue-like formations with these bioactive glasses, evident of the osteoinductive effect of these bone fillers. But our interest was, in recent years, was much more focused on this material known as Civitarani materials. And perhaps 10 minutes or so, I would like to focus on Civitarani material that we were focusing more on this recent time. So perhaps it may be very new to you, or maybe you may have heard this word Civitarani. The Civitarani materials or Civitarani molecules have this cationic and anionic region, which are overall charged being neutral. So if you look at this picture here, it has positive tail or negative tail or cationic groups or anionic groups in these single molecules, but overall charge of this molecule will be neutral. So this is very similar to the phospholipid structure of our cell membrane, where we have polar head and non-polar tail to maintain this unique structure. There are three major Civitarani materials that's been investigated and used, or applied even. The MPC is perhaps more old and commonly used Civitarani materials, and other things are SBMA and CBMA, which are meant to be more cheaper and recent in terms of the advancement of these Civitarani materials. All these materials have polar or non-polar region, or a cationic and anionic region, and overall charge being neutral. Because of this unique structure, it has a hydration shell that's been formed on those particles, which means that they have a large proportion of free water that forms a thicker hydration layer, and that provides a stronger attraction force to individual water molecule. And because of this structure, unique structure, they have what is known as the anti-biofouling nature. They prohibit the non-specific protein absorption, and thick hydration layer formed around Civitarani polar groups will prevent initial bacterial adhesion and biofilm formation. So this material has been heavily studied in medicine or other field as part of these anti-biofouling or antibacterial adhesion materials. So we wanted to investigate these effects as well as incorporate it into dental materials initially. So we wanted to see whether these effects are as been advertised. So we incorporated this MPC, the one of the Zivitrine materials, into very simple materials like curable fluoride varnish. So this is how we added. So different contents of the MPC been added into light curable fluoride varnish. So as you can see here, at the low contents of this MPC, the physical properties are pretty well maintained, as well as degree of conversion is pretty maintained even at 20% MPC. But with the amount of peripheral absorption, it was very evident that the previous studies were being confirmed. That we at the 1.5 to 5% of the MPC, the amount of absorbed BSA, the bovine serum albumin, is dramatically reduced, as well as the proteins from the BHI medium. The interesting thing was that increasing MPC actually did not prevent the absorption further. It actually going back to normal control, so it actually increases the absorbed BSA. Its perhaps the reason is that the interaction between the MPC molecules with the surrounding matrix that is preventing the MPC to be active in terms of the exposure to the surfaces. But certainly it has effect in terms of antibacterial properties. At even low dose of 1.5% to 5%, it reduces a attachment of Streptococcus mutans attachment, as well as two other early colonizer of biofilm, which has been significantly reduced by just 3% of MPC added to fluoride varnish. So we wanted to see whether this will be effective in clinicals. So to mimic the clinical situation, we have this section of animal and dentin, where we have one with the no varnish, just simple varnish without any MPCs, and 3% varnish. As you can see here, the thick layer indicates the 14 days after exposure to Streptococcus mutans, resulting in a decay of this layer. And as you can see here, the fluoride varnish have some prevention, but still there's some this black area of decay. Whereas incorporation of 3% MPC has very good effect in terms of prevention. And this can be dramatically shown in this picture on the right, where we have division with control and 3% MPC, and this will dramatically reduce the number of bacteria attached, as indicated by SEM images, as well as disclosing agents results, as you can see here. So we wanted to incorporate into this number of different materials. So we then published a lot of papers to see whether this has a potential to be incorporated in different materials, such as 3D printing materials like here. So the incorporation of Zivitrine materials was pretty much possible on many different materials, and this was much durable in many sense. So when we consider a before and after aging process with thermocycling, the effects were pretty much maintained because they are pretty much locked into this polymer matrix and provide a effects as a Berg form. So this is different to just surface coating, I think, because surface coating may have some aging effect, but because this is incorporated into the polymer itself, the effects much more durable, and it did not have any negative effects in such as accuracies or physical properties or other mechanical properties as we investigated. But our interest then go further when we carried out these experiments that's been published in 2019. So the idea was to just like last time we incorporated Zivitrine materials into glass ionomers that has a pre-reactive glass ionomers, surface pre-reactive glass ionomers, SPRG. The idea was just to provide a antibacterial effects and see whether the ionic release from the glass ionomers will be modified by it. As usual, the low dose 1.5% to 5 to 7.5% result in a reduction of attachment of bacterial colonies, as you can see here. So this is what we already found out from our previous papers. But surprising results were found from this table. When we added the MPC and when we increased the amount of MPC in the composite, it was noted that if you look at this mean number, the amount of ion release for each ion is actually is dramatically increasing as we increase the MPC amount. So this means that the ion from the glass ionomers, the ion from the SPRG, are for some reason released more into the matrix and then released more into the outside that we detected. So we wanted to investigate this further. We wanted to know why this is happening. Maybe just simple increase in solubility because of this lack of polymer integration, polymer matrix integration. But we wanted to know more about this phenomenon. So we gone further and we published this paper very recently. And this paper is currently online published and waiting for a page number. And this was really a multiple effect from different departments to investigate this effect. So here, what we prepared was just glass ionomer with fluoroaluminum silicate, but also fluoro-zinc silicate. So zinc-containing glass ionomer, I think, which is a very recently prepared. We wanted to have some very newly available glass ionomer materials. So we had this as a control, and we call this polyarachidonate cement, whatever it's called in medicine. And we had two different experimental groups with this control. We added a single zivitral materials, which is MPC, we called SZM, and also multiple. So we had two different zivitral material, which is SBMA and MPC. We call this MZM. So control with this just glass ionomer with fluoro-zinc silicate, and SZM for a MPC with this control, and MZM for SBMA plus MPC in this control. So in terms of the addition of bacteria, it is as expected. Well, no matter what kind of zivitral materials we have, there is a significant reduction of bacterial attachment. This, mind you, is a very new glass ionomer material with a performance that has been stated to be antibacterial, so it's even greater than zinc-containing glass ionomer in terms of the prevention of bacterial attachment and perhaps killing of these bacteria. And in terms of the oral biofilm, also the effects were what we expected. There's a dramatic reduction of the oral film formation and attachment on this surface, although you may say the layers are much more thinner with these multiple ZM materials. But effects were much more dramatic when we consider a ion release and bioactivity related to regenerative effects. In terms of ion release, as I said earlier, the addition of zivitral materials into glass ionomers for some reason increase ion release. But more surprisingly, when we have multiple different zivitral materials, the release is much more dramatic, as you can see here. And this was evident in solution pH, where the neutralization of the pH was more different in pattern when we have a single or multiple zivitral materials. When we look at the apatite layer formation, the control layer did not have any apatite layer formation, but single zivitral material have apatite layer formation. But when we have multiple zivitral materials, the layer was much more thicker. And this was evident with ex vivo studies, where we have a demineralized animal, and also in vivo studies with canine model. The multiple zivitral materials certainly have a remineralizing and or just mineralizing effects. Then we went further to try to find out what will be the basic mechanism behind it. We found out the MPC and SB have different lateral polarity, as you can see here, the molecular lengths or overall the polar end of these molecules. When we have a similar molecules, so when we have a just MPC without any SB on it, for example SZM, this will result in a saturated form of dipole moment. But when we have a mixture of these two, as you can see here, block, there's a disparity of this polar nature, and causes multivalent zwitterionic materials. This multivalent zwitterionic materials is very interesting because it causes a disturbance of binding oxygen and non-binding oxygen of the glass particles. So because of this phenomenon, the glass particles from the glass ionomers or whatever is having a formation of ion release channel formation. And this will allow ion to be released from these glass particles to outside very easily. So this phenomenon has been confirmed, and we try to find out what kind of mechanism studies that we can do further to find out this interesting phenomenon. But another interesting thing is this result, the microbiome results. As you probably know, saliva is full of different microbiomes. When they are exposed to dental materials like a zinc-containing glass ionomers, the microbiome change dramatically. You can see here. So it's much more like a very low abundance of just single or less bacteria remaining, because obviously we're having bactericidal effects. But when we have these zwitterionic materials, especially the multiple zwitterionic materials, the variety are preserved, and even with the multiple zwitterionic materials somehow increased. We don't know why, but perhaps this is because the zwitterionic materials is not bactericidal. They are just preventing bacterial attachment, and also they have some positive effect with the ion release. Some sort of ion releasing effects are having an interaction with microbiomes and therefore being more microbiome friendly. But obviously these results are very preliminary, and we are doing more researches to find out the interaction with this kind of so-called antibacterial, antibiofouling dental materials or any kind of dental materials with our oral microbiome. So we hope to research and develop this further and produce a products, and also because of this interest with standardization, I want to put this as a standard later on. But obviously we cannot do this alone. We want some collaboration between many different researchers, and hopefully we can have some collaboration from participants of this symposium today, so we can have some development of new and better dental materials for clinical field. So thank you very much. So this is my lab crew. I would like to be very thankful. I'm very thankful to my lab crew. They've always been very helpful and produced this huge amount of work and published a lot of papers. And we are looking for a brighter future on 2022 and later on as well. Thank you very much.
Thank you. Thank you, Professor Kohn. And your lecture was really impressed me. Thank you very much.
Thank you.
And yes, this keynote lecture is open for discussion. The one question has Professor Takashi. Does MPC still have an inhibitory effect on bacterial adhesion once coated with saliva?
Oh, I see. So you mean the MPC, the question, I'm not quite sure whether the question is related to saliva coating and then MPC coating, or MPC and then you have saliva on top of the MPC. I think the later one is a question. So if we have MPC, although saliva is coated, their protein, the adhesion protein, cannot be attached onto the MPC. So it will be prevented from attachment in the first place. So as you probably know, the salivary protein is the pellicle protein is a key role in bacterial attachment. So because they cannot be attached on the biomaterial first place, it will prevent the bacterial attachment.
Okay, thank you very much. And other questions? May I ask one more question?
Yes, sir. Yes, sir.
And you, concerning MPC molecules, you showed with the increasing MPC in the materials, the ionic release also increased. Could you explain the possible mechanism to increase using
So that phenomena only occurred when we experienced with glass ionomer based restrictive materials. First of all, we did not know what was happening. We first thought that's just an error in making sample, but more and more we study, we find out actually MPC, because of their polarity, their unique nature of polarity, they interfere with the binding oxygen and non-binding oxygen of the glass molecules. Because of that, I think they interfere with the glasses and therefore increase the release of ions from the glasses.
Okay.
We have some evidence that, but at the moment we are actually undergoing patent and developing material with that.
Right. Thank you very much. Yes, although there maybe have a lot of questions from the audiences, but the end time has come. So thank you very much for Professor Brown. Thank you very much. Right. Yes, so can you see my slides, Sensei?
Yes.
Okay. So I'd like to present my work entitled Bioactive Properties of Newly Developed Bone Substitute Induced by Materials Self-Interaction. There is no conflict of interest. As you know, well, the bone is remodeled by osteoclasts and then osteoblasts to form new bone matrix. And during the formation of a new bone, bone apatite crystal so deposits on the collagen matrix. In the octocalcium phosphate, OCP is considered a precursor to apatite crystals during bone mineralization. So far, we have been developing various OCP-based bone substitute materials. They include a OCP composite with natural polymers such as collagen, gelatin, alginate hyaluronic acid, and polylactic co-glycolic acid PLGA. It is interesting to know the type of matrices used to affect the composite biological performance. Among these composite materials, OCP collagen composite is now approved for the use of the oral surgery with dental implant. Leading to the 60 clinical trials, including implant placement, and the osteoconductive property was found by establishing the synthesis of a bench scale synthesis method. And we have found CP had a higher osteoconductivity than hydroxyapatite. And then we have developed CP collagen, which superior has a osteoconductive property than OCP alone through collaboration with Nippon Ham Meat Company. And then the 60 clinical trials in Tohoku, clinical trials in Tohoku University, and then a company initiative clinical trials has been conducted in the 9 medical institutions in Japan. In this clinical trials, Professor Tetsu Takahashi of Tohoku University is chief doctor in this study. So this was approved now for the use of with dental implant. This is my topics I would like to talk today. The first, what is OCP as a biomaterial? Then the second, development of an OCP composite with natural polymers. I would like to explain about OCP collagen. And finally, distance OCP capacity for osteocytes and autologous bone. So first topic. As you know, hydroxyapatite is usually considered a prototype for bone and tooth apatite crystals. And the hydroxyapatite can be formed via amorphous calcium phosphate, and the ACP can be converted to OCP-like structure and OCP-like structure convert to hydroxyapatite. So OCP is a direct precursor to hydroxyapatite. As you know, well, there are many calcium phosphate materials. Among these calcium phosphate materials, beta tricalcium phosphate and hydroxyapatite ceramics used clinically, but autogenous bone is still gold standard material as the implant. So better bone substitute materials is usually required to develop. Then we paid attention to the OCP because OCP has a higher osteoconductivity than hydroxyapatite. This is an example of a characteristics OCP property as a biomaterials. When the OCP granules is implanted into critical sized lateral valve defect, CSD, the OCP enhances bone formation more than hydroxyapatite. And when we look at the crystal structure of OCP implanted in vivo, OCP can be converted to a hydroxyapatite progressively. So we concluded that OCP enhances bone formation during OCP HA conversion processes. This is another characteristic of OCP. When OCP granules are implanted into rabbit fiber, the granules disappear with time. So this means that these materials could be biodegradable materials. When we look at the histology, this is on the calcified hematoxylin and eosin staining specimen. And we appreciate multinucleated osteoclast-like cells directly attached to the surface of OCP granule. So we concluded that OCP is one of biodegradable biomaterials. And another feature of this OCP, if we look at the initial dosai of bone formation after implantation of OCP, this is an example of mouse cerebral implantation. We can see the accumulation of non-collagenous matrix protein around the OCP1 crystal. This is the transmission electron microscopy. So we are interested in knowing about what kind of proteins are accumulated around OCP. So we conducted a MS spectroscopy. We have investigated the absorption of serum proteins by incubating OCP or hydroxyapatite granules in the rat whole serum and extracted adsorbed protein via guanidine HCl, which means that the calcium binding protein can be collected. And we analyzed the liquid chromatography tandem mass spectroscopy to identify the proteins adsorbed. The 138 proteins are detected on OCP and 103 proteins are detected on HA, and 48 of which proteins are common proteins, and this table shows the common proteins, and we see the alpha HS glycoproteins, and another it's apolipo-E precursor ApoE protein and the complement C3 proteins. And we are interested in the ApoE and C3 because these proteins, ApoE, he has a capable of stimulating osteoblast differentiation, and the complementary C3 is a protein to recruit osteoclast precursor. So maybe these proteins are involved in the expressing osteoconductive property of OCP. And let's move to the second topic, development of an OCP composite with natural polymer. As I explained before, we investigated various composites with natural polymers. In the one of collagen, one of composite with the collagen is now approved, as explained before. Although I did not explain about the in vitro result of the dose dependent of OCP on osteoblast, osteoblast has a capacity to induce osteoblast differentiation dose dependently. So we investigated the effects of OCP dose in vivo using these OCP collagen composite, including from 30 to 83% of OCP. So you can see the gradual increase of radial opacity with increasing OCP content, so that the dose-dependent effect also can be expressed in vivo condition. And we investigated regenerated bone quality by OCP collagen implantation. And you see the gradual increase of radial opacity over the time. And this is a rat critical size to defect model. And this figure indicates the bone formation gradual with, you see the gradual increase and also gradual decrease of the remnant of OCP. So this is the biodegradable and a property as I mentioned before. And also we investigated the hardness of the regenerated bone. The because hardness will increase gradually, and the toughness, fracture toughness also increased, approaching to the intact normal bone. So this means that the regenerated bone induced by OCP collagen has a similar property in terms of mechanical property. This is a experiment using big doc conducted by Dr. Tadashi Kawai of Iwate Medical University and published in Materials. And after the extraction of the tooth, the implant inserted into the defect, and also the implanted the autologous bone and commercially available beta TCP granules are implanted around the implant. And you see after the 3 months, although the untreated group still has a radiolucent zone, these 3 groups are very high radial opacity. And if we look at the percent bone implant contact, the OCP collagen and autologous bone has higher BIC percent compared to beta TCP and also untreated group. So just OCP collagen has their capacity, the new bone in the clinical situation in the experiment. So I'd like to move to the final topic, this time to OCP capacity for osteocytes and the autologous bone. As you know, osteocytes differentiate by expressing through the podoplanine, ALP, the social sclerostin, DMP1, and the FGF23. And IDG-SW3 cell line, which is the mouse bone marrow derived mesenchymal stem cells, is capable of differentiate into osteocytes by expressing these markers. And DMP1 can bind to the promoter region of under a GFP gene bound to DMP promoter, so we can investigate the differentiation of IDD SW3 in the presence of the materials. And this is an example of the investigation of the effect of OCP on the osteocyte differentiation in comparison with HA and beta TCP. And we have used a trans-well cell culture, so that this means that we can investigate the effect of OCP in the no contact environment of the material. And we see the gradual increase of DMP1 expression in most in OCP materials. So OCP enhanced expression of DMP1 more than the two materials until 35 days. And if we look out to the expression of source sclerostin, this data shows OCP enhanced most the differentiation of osteocytes as well as DMP1. In the if we analyze the calcium and phosphate concentration in the medium, in the phosphate ion in after the incubation OCP has higher concentration compared to other materials, so that this suggests that the phosphate ion had some effect of the differentiation of osteocytes. So we pay attention to the phosphate ion in the osteocyte differentiation. This figure shows the effect of phosphate ion concentration in conditioned media in the absence of OCP materials. This is just the effect of phosphate ion concentration. And with increasing phosphate ions, the ALP activity increases up to 1.5 millimole. That decreases over the 2 millimole. So now this investigation, they suggest that the phosphate ion concentration controlled by the OCP materials may affect osteocyte differentiation. And I would like to mention about the mutual chemical effect OCP and the autologous bone implantation. At the beginning of my presentation, I mentioned about the some of mechanism of OCP. OCP can be converted to calcium deficient HA, which by enhancing hydrolysis OCP at physiological pH. During this process, various ion incorporated, and also the phosphate ion released from the material. And also we understand that this conversion process activates bone tissue cells such as osteoblasts, osteocytes, although I did not mention about these osteoblasts and osteoclasts here today. So we pay attention the effect of ionic dissolution products from OCP for the to know the effect of OCP and to know the why OCP has a higher osteoconductive property more than the other calcium phosphate materials. We prepared autologous bone harvested from rat calvaria by when creating CSD from rat calvaria, and also prepared OCP granules with having 500 to 1,000 micrometer diameter and mixed, and then implanted into the lateral defect. And this is a CT, and this is the histomorphometric analysis of the bone formation. And you see, although autologous bone show a most bone formation enhanced the most, but the mixture of OCP still maintain the capability of bone formation as a mixture of autologous bone. And so we would like to know how the OCP enhances the ability of the osteogenic property when mixing like this. This is the in vivo experiment conducted by using transfer culture cells also, and we have used the MSC T1 cell line, and we investigate the effect osteogenic differentiation of T1 cells in the presence of materials and autologous bone, materials alone, autologous bone alone, and mixture. We observe the surface of bone without in the presence of OCP. Some deposit can be seen like this, but in the presence of OCP, the bone surface showed like a collagen fiber-like structure, which means that the bone surface could be eroded by the presence of OCP. So this suggests that some mutual chemical effect has been occurred. So we analyze the differentiation of the T1 cells, and this is a result of LB activity. And you see, we mixed OCP with autologous bone. This condition enhances the osteoblastic differentiation of MSC. So this is a result standardized by the autologous bone per weight. So this means that the OCP could enhance the osteoblastic differentiation existed in the bone. So this is the result showing suggesting that the mutual chemical effects of OCP and autologous bone. And this is a summary of a mechanism of OCP enhancing bone regeneration. In the during OCP hydrolysis to calcium deficient HA, some of ionic dissolution could be produced from OCP and enhances some of bone-related cells such as osteocytes. Even the OCP has a distant places. In the this is the final slide. So this is the summary of my presentation. OCP and composite materials, including collagen composite, have successfully been developed for the clinical use. OCP is a material which can stimulate bone-related cells from distance. I'd like to say acknowledgement for many collaborators in the Tohoku University Forsyth Institute and the Showa University, Saitama University, and our lab members, and also would like to say thanks financial support, including Next Japan. Thank you for your kind attention. Okay, thank you. So this is my presentation. Do you have some questions from audiences? Oh, one question. higher fracture toughness of OCP collagen complex was quite impressive. Is it similar or see the toughened of natural bone? Thank you for the question. The results show that the bone quality it could be compatible to the intact bone, but data show that the toughness and the hardness could be higher than the intact bone, but we think that bone quality could be similar with the intact bone. Is that enough? Thank you. Okay, thank you very much. Okay, so thank you very much, and audiences, and thank you to all the professors who gave us a wonderful lecture today. We would also like to thank everyone at the attendance. So this session will end. Thank you very much.
Thank you very much, Professor Suzuki. This concludes the symposium program, and the closing and outstanding poster award ceremony will be held soon. Please little bit wait. Okay, let's start with the outstanding poster award ceremony. Professor Hong, please start it.
Okay, thank you very much, Dr. Nishioka. I am Hong, chairperson of the organizing committee of this symposium. Before announcing the award winner, please allow me to express our sincerest appreciation to all of the attenders and also keynote speaker, invited lecturer, on behalf of organizing committee for your great contribution and cooperation to this symposium. Otherwise, we cannot successfully conclude all of the program. Okay, so it's time to announce the outstanding poster award. This time we received 123 e-poster, and from this e-poster we select 17 poster as the outstanding poster award. So the winner is, let me share the screen. Do we need a drum roll? Okay, wait a moment. Can you see the screen now? Can you see? Okay. Okay, so the outstanding poster award, the winner is the 17th person, the P number 14, Dr. Kalita Nakaleka Limjalak. It's correct, I don't know. Okay, from Chulalongkorn University, Thailand. And P25, Dr. Han Yuan from Tohoku University, Japan. P35, Dr. Mefina from Erlangga University, Indonesia. And the P39, Dr. Agustin Ulanchi Dharmayanti from Jemba University, Indonesia. And the P41, it's co-presented from Dr. Akalin Klala and Dr. Tu Linnea from University Gothenburg. And P54, Dr. Wanakong Suryaji, Chulalongkorn University. P56, Dr. Shunichi Shishido from Tohoku University. P611, Dr. Mei-Ling Hu from Tianjin Medical University. And P612, Dr. Liang Yuxing from Tianjin Medical University. And P71, Dr. Mai Kameda from Tohoku University. P72, Dr. Xiaoxia Su from Sichuan University. And P81, Dr. Lavifa Suitayalak, Chulalongkorn University. P813, Dr. Yalan Deng from Sichuan University. And P911, Dr. Primanda Noor Lamania, Erlanger University. And the P913, Dr. Susinum Saksu Fang, Prince of Songkla University, Thailand. And the P97, Dr. Yannan Huang from Sichuan University. And the P1011, Dr. Mingyue Wang from Peking University. Okay, congratulations. We will send our certificate within the next week. And congratulations again. Okay, thank you very much. I will back over the microphone to the Dr. Nishioka.
Okay. Thank you, Professor Hong. Congratulations for all the winners. Next, we will begin the closing ceremony of the International Symposium for Interface Oral Health Science 2022. First of all, Professor Minoru Wakamori, Vice Dean of the Graduate School of Dentistry, Tohoku University, will give a closing address. Please.
I'm Minoru Wakamori, a professor of dental pharmacology and a vice dean of Tohoku University Graduate School of Dentistry. I would like to express my gratitude to many researchers for participating, even though we held the symposium on Saturday and Sunday. It is a great pleasure for us to hold this 9th symposium in the year of the 20th anniversary of the launch of the concept Interface Oral Health Science. In the year of the 115 years anniversary of Tohoku University and 100 years anniversary becoming to comprehensive university. Because of the COVID-19 pandemic, the symposium was not on-site, but virtual meeting using Zoom. We want to discuss the topics face-to-face, but one of the benefits of Zoom meeting is that it is easy to participate. Therefore, we had more than 110 poster presentations. We are happy to have more presentations than we expected. In this 9th symposium, we had Campus Asia Plus Symposium in the first keynote session. Campus Asia Plus is supported by the government from last November. This program strengthens our friendship and partnership. Because only our dental school has the Campus Asia Plus in Tohoku University. Our university expects to expand friendship to other schools or faculties in your universities using our close relationships. In the keynote session 2, we had the first international symposium, Shokugaku Research, that started in Tohoku University 2 years ago. We have to deepen the conventional dental research field. In addition, we have to expand new research field as oral health sciences, where we give the achievement back to the society. Our dental school hopes collaboration with you on the Shokugaku research as well as the dental research field. Through this symposium, we confirm the friendship and partnership, and we exchange the idea. We hope COVID-19 pandemic will end soon, and we want to meet in the next International Interface Oral Health Science Symposium. Once again, I would like to thank both the speakers and the audience from all over the world for providing many interesting sessions and discussion.
Thank you very much for your speech. Next, we would like to invite Dean and Professor Isong Kim, College of Dentistry, Yonsei University, the lead to the video message.
Good evening, ladies and gentlemen, distinguished guests, and fellow colleagues. It is a pleasure and honor to be here with prominent scholars from Japan and the other countries. First, I'd like to express my sincere appreciation to Professor Nobuhiro Takahashi and Professor Hong Kwang for inviting me to become an honorary member of this symposium, and for giving me the opportunity to make this closing remark. I also appreciate the special contributions of all members of the organizing committee. The topic of the symposium has embraced a number of current dental issues regarding oral health, from health to disease, and from cell level to epidemiologic level. I was also inspired by the use of big data from various countries for improving oral health. As you are aware, for the past 2 years, we have been experiencing extraordinary situations in which we were forced to be separated from each other or from our neighboring societies. Nevertheless, we must continue to unite and work towards the common goal of pushing the boundaries of innovation and improving oral health for all people from all over the world. Here, I saw a clear trace of our steady efforts for the movement to this end. In line with this objective, we are now starting the Asia Campus project by cooperation with the 7 universities from 5 Asian countries. All students from these universities are open to each other with this chance. They can carry out academic and cultural exchange in each field of dentistry and develop themselves and interact with each other. So, we should be proud of the beginning of this project and this International Symposium for Interface Oral Health Science 2022 as the starting point of our new wave. I sincerely look forward to active academic exchanges and research collaboration. Once again, I wish to extend my deepest appreciation to Professor Nobuhiro Takahashi and Professor Hong Kwang for this chance to give this speech. Even though this is the end of the symposium in 2022, I hope all meaningful steps will continue from now on. Thank you.
Thank you very much, Professor Kim. Next, we would like to invite Dean and Professor Lin Ye, West China School of Stomatology, Sichuan University. It's also a video message.
Dear Dean Professor Takahashi, distinguished colleagues and friends, on behalf of West China School of Stomatology, Sichuan University, I would like to congratulate Dean Takahashi and the organizing committee from Tohoku University for the success of the International Symposium for Interface Oral Health Science 2022. I still remember that 4 years ago that I was in Tohoku University for the IOHS 2018. I quite enjoyed the scientific meeting as well as the social part. We made a lot of new friends there. In the past 3 decades, our dental school and the Graduate School of Dentistry Tohoku University enjoy a long time and a fruitful cooperation. A lot of faculty members and students from our 2 dental schools have paid their visits to each other. We also established a vigorous PhD joint program and carried out a lot of joint research projects. Some of the graduates from Tohoku University became our faculty members after coming back and made a lot of contribution to the progress of our dental school. I firmly believe that with the leadership of Dean Takahashi, our friendship and cooperation will be promoted to a whole new level. Recently, our two schools, along with other 5 prominent dental schools from China, Japan, Korea, and Thailand, were granted the CAMPUS Asia Plus program. This program marks a new beginning of sustainable network in Asia for joint education, research, and clinical partnerships in dentistry. Not only the faculty and students from the dental schools in this program, but also and ultimately the people within this region will benefit from this novel platform of cooperation. West China School of Stomatology will be more than happy to work closely with our partner schools to make CAMPUS Asia Plus program a new model of international collaboration in the dentistry field. Due to the COVID-19 pandemic, it's regretful that we can't meet in person. I would love to take this opportunity to invite our colleagues and friends to visit our school in the possible nearest future. Once again, please accept my warm list. Congratulations on the success of IOHS 2022 and wish everyone a happy and prosperous new year. Thanks.
Okay, thank you very much, Professor Ye. Finally, we would like to invite Professor Melissa Adiatman, Faculty of Dentistry, University of Indonesia. Please give us a speech.
Good afternoon. Thank you very much for the opportunity. On behalf of our Dean, Dr. Nia, so actually University of Indonesia is recently have a new Dean. I will introduce her later in other opportunity to Professor Takahashi and Professor Guang Hong and all members of Tohoku University. So from Professor Linda, we have new Dean, her name is Dr. Nia. So she will be involved in the next upcoming collaboration. So first of all, I would like to say thank you for Tohoku University to invite Universitas Indonesia to become one of the collaborators for the Campus Asia Plus program. We really appreciate this invitation, and we want to congratulate the organizing committee for having the symposium really successfully organized. The Interface Oral Health Science 2022 has given a lot of very wonderful presentation, and it is a very good opportunity for our graduate and undergraduate students to study and to see what is other people doing in their research program. So we really want our exchange program or international mobility program to establish a higher educational network among universities to improve the competitiveness of our students, especially in Asia, to become very competitive in the international academic market. And we want our students to become the future leaders that can succeed in the global community in research and academic program. So once again, thank you very much for inviting us. And we really hope that in the next upcoming Interface Oral Health Science Symposium, we want to spread this information wider so we can get more posters, more presentation, and make the symposium more successfully. Thank you very much.
Thank you very much for your speech. This concludes the whole program of the symposium. Thank you very much for your cooperation and contributions. We look forward to seeing you in Japan someday. Thank you.
Thank you very much. Thank you, Professor Kong.
Thank you very much, everybody. Thank you.
Thank you, everyone. Hope to see you soon.
Yeah.
In face-to-face.
Hope to see you. Yes, that's right.
Sayonara.
Sayonara.
Oh,
Thank
sayonara.
you. Please pass my gratitude to your dean.
Yeah.
Yes, I will introduce the new one to you later.
Oh, thank you.
Of course.
Terima kasih.
Sama-sama. Bye-bye.
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 ご先生ありがとうございました。
ありがとうございました。
どうもありがとうございました。
皆さんお疲れ様でした。
お疲れ様です。本当にお疲れ様です。じゃあ、
なんとか
失礼させていただき
どう
ます。
もありがとうございました。
西条先生、ありがとうございました。またいろいろとよろしくお願いいたします。
よろしくお願いします。じゃあ失礼します。
失礼します。
ありがとうございました。先生。まあまあ。
ですね。はい。
で、大丈夫ですね。皆さんが退出していただければ。
そうですね。高先生、ありがとうございました。
いえいえ、もう、
素晴らしかったです。
皆さんのおかげで、一応無事に終わりました。その後、ジャヤ先生から実は連絡ありました。
大丈夫でした？
なんかね、オーストラリアに行ってるんだって。シンガポールをもう辞めて、クイーンズランドに。
いつから？
だから今、もう移ったばっかりで、今、隔離中ですって。
なんだそりゃって感じですね。じゃあ、そちらに転出したってことなの？
そうですね、転職でクイーンズランドに行って、はい。
どういう職に就かれたの？
まあ、そんな詳細はまだ聞いてないんですけど、多分まあ教員にはなるはずなんで、一応クイーンズランドの連携を進めましょうっていう話で、ぜひぜひっていう感じで。
いや、なんかすごいですね。あれ、誰でしたっけ？サムがそんなふうな経路でしたよね。
そうです。前、サム先生がクイーンズランドの学部長やってて、その時ちょっと話進めてたんですけど、まだ結論が出てなくて。
その後でしょうかね。
そうですね。サム先生は今もう香港に戻ってるんで。
そう言ってましたよね。中東に行ってまた戻ってきたってね。
そうです。
すごいね。まあでも無事でよかったです。何かあったかと思ったんで。
まあ一応生きてるっていう感じでした。すいません。その辺はご迷惑かけてしまって。
本当にありがとうございました。非常に
ありがとうございました。
それでは失礼します。
お疲れ様でした。
またよろしく。失礼します。